using the metoprolol and ketoconazole to treat Cushing. So that means they can affect the adrenal gland and suppress its action. So if the patient is taking ketoconazole as antifungal and you found he has Addisonian symptoms, so this could be due to the inhibition or suppression of the adrenal gland. Does that make sense? So add to the ketoconazole and metoprolol, add to them phenytoin. This phenytoin is a big criminal. Phenytoin, barbiturate, and rifampicin. Phenytoin, barbiturate, and rifampicin. Okay. Okay. What about after drugs? We want to go to another degenerative disease. And I think in degenerative here it was related to amyloidosis, but I add amyloidosis up so you can just remove it because I divided to sarcoidosis and amyloidosis. Okay, so again, just nothing for this. Then infections. Infections is very important here because it's very common in the exam. What is the most common infection that can cause? Yeah, Dr. Rashid Islam. Yeah, TB we already done. Dr. Khalid, Dr. Gresh, TB we already done in the first T up. Because TB is again is very important, but HIV is the most common. HIV is very common to be the cause of the Addison disease. Okay. Other infections, yes, meningococcal adenovirus. There is meningococcal adenovirus, and there is cytomegalovirus adenovirus. So you can, yeah, excellent for Dr. Mahan, Dr. Nawader, and Dr. Khalid. Yes. So meningococcal, how will you ask? You ask again, rash, neck stiffness, headache, fever, exposure to sick person. Maybe in the scenario, she had a son who was diagnosed with meningitis. What if they said that? They can say that. So they are pushing you toward that the patient now has this Addison because he has meningococcal septicemia. Yes. Be smart. Just try to use your mind. Yeah. Waterhouse syndrome. Yes. Yes, it is. What about sarcoidosis? Do you remember how to ask about sarcoidosis? Just 3 questions. If the examiner will understand. Shortness of breath, joint pain, rash on the chin. Okay? Painful rash on the chin of your leg, and joint pain and shortness of breath because of adenopathy and fibrosis. Great, exactly. What about Nelson syndrome? What's Nelson syndrome? Do you know what's Nelson syndrome?
Bilateral adrenal removal.
Yeah. You will ask about the surgical history. He will tell you that they removed the adrenal gland or partially removed the adrenal gland because of cancer, because of anything, because of a congenital adrenal hyperplasia. Then the patient will have what's called the Nelson syndrome. Okay. Then the most super important cause for the Addison, the star of our night today, is the steroid withdrawal. Steroid withdrawal is the most common cause in Addison worldwide because the people taking steroids are millions and they just hate it. You just watch the TV and found the doctor talking, not the doctors actually, this criminals talking about how harmful is the steroids and it's like a poison and it's like, so every patient in the world you will find that he's talking about steroids like a poison and you don't know that you can't even, if there's no steroid, half of the people in the world will die. So every one of us have an allergic attack, everyone have bronchial asthma, everyone have one in his family has a rheumatological disease, and they all need the steroids. So you found that the patient decided to stop this medicine that Dr. Tan wrote for him because this Dr. Tan is idiot and he wanted to destroy my bone and he wanted to make a hole in my stomach because he wrote for me this steroids. Then he suddenly decided to stop it. Then after 3 days he is in ER and in ICU because he tried to watch the TV and believe these people. Okay, so steroid withdrawal is super important as a cause of Addison disease. Okay? It looks long and heavy, and I know, but again, you remember, I'm giving you the algorithm and then I give you how to approach it. So it's not long. You asked it during, before, during, after, then you found it looks like hypo. It looks like just a syncope. So you found, you asked about postural hypotension, you found yes, and no hypoglycemia. It doesn't look like Addison, no other symptoms of Addison, no tummy pain, no weight loss, no pigmentation. So I just checked the hypovolemia, and I found the patient is on diuretics, and that is it. I'm done. Okay, or I found that postural hypotension and the patient has slowing in movement and rigidity in his arms. Yes, it's done. It's just Parkinsonian plus with maybe child dragger. Okay, autonomic affection. A long-lasting diabetes. Okay, catch it, and I get my marks. But what I found is no postural hypotension and hypoglycemia. I will search. Why does patient have hypoglycemia? He's drinking a lot of alcohol. She has a problem with her husband, and she keeps taking this antidiabetics to show him that she's very sick and take some love. Okay. So whenever I found both of them, postural hypotension and hypoglycemia, so I'm done. It looks Addison. I will confirm my diagnosis, again, as usual. Confirm my diagnosis by asking the other symptoms of Addison. Then search for the cause by checking the Addison mnemonic. Okay, after checking the cause, I'm going to check the complication. What is the complication of Addison disease? Right in the chat box. Great. Adrenal crisis. And what is the symptom of adrenal crisis? Just the same as the Addison disease. It's severe vomiting, diarrhea, abdominal pain, hypotension, hypoglycemia. There should be a shock and fever. Yeah. And if you correct this patient hypoglycemia without steroids, you will kill the patient. Why it happened? Do you have any idea why adrenal crisis can happen? Stress. It could be organic stress and could be physiological or psychological stress. Physiological could be with infection. How to treat? How to treat the Addisonian crisis or even the Addison? How to treat? Do you have any idea how to treat the Addisonian crisis? Okay, just watch that. Okay, I will make it more easy for you to remember. Yes. Just do that. Okay, do big S. You see my writing, big S. Steroids, saline, sugar. You see how to treat it? Steroids, saline, sugar. Okay? Yes, steroid could be, you are giving hydrocortisone and you could give cortisone. Okay? So it's triple S, steroids, saline, sugar. This is how to treat the, no screen? You can't see the wall? You don't see my wall? Doctor, do you see the algorithm or not? Dr. Grace said, yes, we see it. Dr. Rashida, maybe you close it. Yes, everyone say that they can see it, Dr. Rashida. Maybe you just minimize it. Okay, you see, okay, so the treatment of Addison is big S, steroids, okay, saline, and sugar. Okay. Yes, Dr. Ashraf, I agree. I agree with you. Dr. Ashraf saying that the hypoglycemia in Addison is late and in advanced case. Yes, that's true. Okay. In the exam, they will mention something about hypoglycemia. And even if not, with you have in the differential of your postural hypotension, the adrenal failure. I mean, it doesn't mean if you don't have hypoglycemia, it's not adrenal. If you found that there is postural hypotension, you will confirm your diagnosis. And how to confirm it? By presence of tummy pain, loss motion, pigmentation, weight loss, right? So when you just confirm your diagnosis by this, you found postural hypotension, you will go through this part, you will find there is adrenal failure. You should ask about hypoglycemia. If yes, it's okay. If not, you still confirm the diagnosis of adrenal failure, so you'll go to search for the cause. I totally agree with you, Dr. Ashraf. It shouldn't be 100% there. It can happen late, but still the adrenal failure is a part of the postural hypotension itself, without even hypoglycemia. But whenever they are both together there, you should know that they are pushing you toward the Addison. Okay? Okay. Tell me, give me the okay for this part, because I will go to another part of the seizures. Are you okay with this part? Are you okay with this side of the page? Is it tough? Not yet, Dr. Rana. I will go to this now. I am going to this left part of the page. It looks like heavy, but when you implement it, Dr. Rashida said it's heavy. Yeah, but when you collect it, if you want to study this from sources, you will read 20 or 30 pages. But here you will have one page. You will find going with carotid sinus and going with postural hypotension. Once I found postural hypotension, I start thinking about Addison and they try to exclude the other things. I found it looks like Addison. I will go to ask about hypoglycemia. Maybe I found it's not postural hypotension and it's only hypoglycemia, so I will go to this differential. I found both of them. I will know that he mean Addison. Once I found Addison, I need to follow my things about the etiology and complication and then association. And to remember that I want to specify, doctor, it's not a condition to have hypoglycemia or to diagnose Addison. For the Addison, as we said, it should be postural hypotension, tummy pain, loss motion, weight loss. Okay, pigmentation if it is not panhypopituitarism. Okay, so in this case, I mean hypoadrenalism is called. If it is an Addison, we will consider the presence of these symptoms. So I didn't mean here. I mean when there is postural hypotension with hypoglycemia, this is, don't be confused, this will be going with the Addison hypoadrenalism. Okay, when it is only postural hypotension, you see, it still can be Addison. It still can be hypoadrenalism, you know. So remember that I didn't mean here that hypoglycemia is a condition to diagnose Addison, but I mean if hypoglycemia is present with postural hypotension, you need to consider the Addison. But remember to confirm your diagnosis by the weight loss and tummy pain and loss motion and the pigmentation and all these questions, okay? Please tell me in the chat box that it's clear. Tell me that this part till now is clear. I know sometimes it's confused and all it is long, but actually remember, in the first page, then you have to see it as I'm describing in this video. Okay, good. Okay, thank you, Dr. Khalil, Dr. Ibrahim, Dr. Wafi, Dr. Sihar, Dr. Ram. Okay, let's continue. Association, it will be hypothyroidism, it may be pernicious anemia, it may be depending on if it's an autoimmune, there is many association could be with Addison disease. So as usual, doctor, never forget. Whenever you catch the diagnosis, go ahead and follow our circle of confirming, complication, association, etiology. Okay? Yes, Dr. Rana, thank you. Then we go now to the seizures. Okay, so we are done with this part. With the seizures, again, you need to know the etiology of the fits. It shouldn't be all the time epilepsy. I want you to know that vitamin D is all plus epilepsy. So I didn't mean that this is all other causes than epilepsy. So we consider it epilepsy, then there's other causes than epilepsy. Okay? It is common to use VIT for the reason for these things. You'll find it. The V for vascular. The V for vascular. What could be the vascular causes of seizures? Write in the chat box, please. Stroke. Okay, Dr. Rana said stroke. What else? Post stroke. Okay, hemorrhagic stroke. I agree. Heavy malformation. Okay, heavy malformation. So you mean hemorrhage? Vasculitis. Perfect, Dr. Kapsar. I like that. So here, vessels is not only hemorrhage. It could be hemorrhage, could be clot, it could be vasculitis. Yes, good, Dr. Islam. It could be systemic lupus. Very good. So clot, hemorrhage, vasculitis. What about clots? Again, the 6 questions. What about the hemorrhage? Again, the 4 questions. What about the vasculitis? I will ask about the PAN. I will ask about the basic disease. I can ask about systemic lupus. Does that make sense? So whenever I found, again, don't be lost inside the station. You ask it and you found. Before, there is some aura. Okay, during they were shaking and he wake up to found that he was in post-ictal and there's a tongue bite and head trauma. Great. So you are done by the first page to know that this is a seizures. Good. The next step in our circles are the reason. What is the cause of these seizures? So I'll start asking about VIT, vitamin for diabetes. VIT for diabetes. So VIT for DM. So vitamin for diabetes. So I'm going to ask about the V. What is the V here? The V for vascular. Vascular referred to hemorrhage as a cause of seizure, blood clot as a cause of seizure or TIA, vasculitis like basic disease, like PAN, like SLE. Okay, and you know that SLE can get fits and seizures and neurological symptoms. That's good for the seizures, for the vascular, then infections. Okay, you'll have fever and neck stiffness, and it could be meningitis, it could be HIV, it could be malariasis. So I mean, some infections when you have this epilepsy, if you will need to ask, was that associated with fever, was that preceded by neck stiffness or whatever, so you can get the answer of the infection as a cause of fits. And very common to find the kid coming and fitting because he has a meningitis or he has any type of infection affecting the brain. Then what about trauma? Patient fell down and he hit his head, he got fits. Okay. What about tumors? Can it cause? Yeah, sure. Tumors can cause fits. Very common to have a patient presenting his brain tumor by fitting. TS. TS is super important in the basis exam. Tuberous sclerosis. Tuberous, we will go through that in our derma. But anyway, the TS is really very important for the, as a reason of epileptic fits. You will find adenoma facium, you will find tuberine patch, you will find Topheolase spots, and you will find seizures. So the patient presentation, they like to bring it as a rash, or they bring it as a history of epileptic fit, and you will find behind it is tuberous sclerosis. I think these things was very horrible, difficult to anyone. If you say, oh my God, how will I approach the TS? But you will not approach the TS. You will approach the seizures. You will ask the question. You will get a seizure. You will go through this question. You will catch that there is a rash. You will tell him, show me the rash. You will look to the rash. You will find it's the rash of TS. So it's clear. This patient have a fits due to the tuberous sclerosis, then 28/28. Then drugs. What drugs can cause epileptic fits? It's the bad drugs. Cocaine, amphetamine, ecstasy, Any bad drugs can cause it. Okay. What about metabolic? What is the metabolic causes of fits? Can hyponatremia cause fits? Hyponatremia? Yes, can. Can hypocalcemia cause fits? Hypocalcemia can cause fits. Yes, sure. Okay. Can so hypo and hyponatremia can do fits. Hypocalcemia can do fits. Okay. Hypoglycemia can do fits. Then uremia, right? What I'm saying because it's not written in the uremia, uremic encephalopathy, high urea and hypertension. These will cause, so this is what's called uremic encephalopathy, hypertensive encephalopathy, hepatic encephalopathy. All of these can cause fits, right? Right? What about the last thing here you need to add? You need to add eclampsia. Eclampsia. Okay? Eclampsia. Yeah, you can add, Dr. Soraya said hypomagnesemia. Okay? Add it to the metabolic. Why not? I don't know how they'll bring in the exam hypomagnesemia and how I'm supposed to catch it. It can come with alcoholic patient. Hypomagnesemia can come with alcoholic patient. Okay? I think the only thing that I know that when the patient has hypomagnesemia, you couldn't correct his potassium. You keep there's this area. Emotional, patient with stress, crying, laughing, okay? Situational, with defecation, urination, or whatever. What the vasovagal feature, it's the patient wake up, don't take more time, maybe 1 minute, 2 minutes. The patient most of the time, he never lost the control of his urine, and usually he's not hurting himself, but he can hurt if he couldn't support his body while falling, okay? Then, if he found it's not vasovagal, it's seizure. Remember, all the time you need to exclude the serious things. So whenever there is a possibility of cardiac or TIA, don't assume it's a vasovagal. So leave the vasovagal to the last part. I mean, whenever you have another serious possibilities, don't assume that it's vasovagal. Okay. First, you need to exclude the TIA, to exclude the epileptic fits, to exclude the cardiac. Then, when all of these are okay, we'll consider the vasovagal because nothing to do with them. Then the seizures, then the cardiac. What is the cardiac that can cause that? You know, right? Like in the chat box, what is the cardiac causes of syncope? Yeah, long QT interval, stroke, aortic stenosis, arrhythmias. Yes. How come? Yes. F. Okay. If makes stroke. How come? Yes, heart block, exactly. Bulgaria syndrome. Okay. What about drugs that increase the QT interval? There's some drugs that increase QT interval, right? Okay. Okay, tricyclic antidepressants, citalopram, antihistamine, great. Yeah, you're excellent. You're all excellent. There's what's called sick sinus syndrome. As if you azithromycin macrolide, you mean the corsara macrolide. Yes, lots of them. Yeah, sure. So this could be the cardiac causes. We said the carotid sinuses. So now you know almost all the differentials for the syncope. We said it could be just vertigo, and if it is vertigo, we'll think about the peripheral and central. We remember this page of vertigo, so you will think the benign paroxysmal vertigo, and it could be neural disease, it could be labyrinthitis, it could be drug induced. This is for the peripheral. For the central, it could be cerebropontine angle tumor. It could be MS. Remember the MS, multiple sclerosis. Okay, this is if it is vertigo. Okay, if it is like postural hypotension, you will go to handy. If hypoglycemia, to re-explain. If Addison, you need to search the cause by asking that Addison. When it is seizures or epileptic fits, you need to search for the reason. And here you will memorize what's called vitamin for diabetes mellitus, BIT-DM. Okay. Okay, give me the okay that you are okay, because I want to give you some hints now about that. There's very important things you should know about this type of cases. Okay, good. Still awake and interested? Yeah, let me tell you what are the most common cases in the exam. Dr. Islam, if you wait, you will catch my point that I'm going to do. Yeah, I know, Dr. Rana, I told you it's difficult. I told you it is not easy. I started, no, it is not very long. When you practice it, it is easy. Don't worry. You don't need to go through all of it, but it is difficult because it has a lot of possibilities. But actually, it's a difficult, tough case in the exam. When you catch it, when you do it that way, you will be the best one who do, and the examiner will give you the full mark. I make it in the 5th day to save time, because now you know what I mean when you say 6 question, 4 question, blah, blah, blah. So I don't need to repeat it. So I know it's tough, and this is very exclusive for you guys. Okay, so in the cases of seizures, how it comes in the exam? Sometime. Yeah, thank you, Dr. Rashid. Dr. Rashid said before this, I was afraid of this spell, but now I'm okay. Yes, Dr. Rashid. Dr. Rashid, you are excellent. Don't worry about anything. You will be the best. How come in the exam? It comes in the exam as a first seizures. Okay, it can come as a first seizures. The patient first time, he has seizures, and that's it. Maybe in communication, maybe in history, just the first seizures, and go ahead and try to check what happened. Maybe it's not seizures. So you'll just dig the first page, found, confirm the seizures, then go to vitamin D, M, and ask for the seizures and confirm the reason, and you are done. Sometimes it came in the history just a confirmed case. You'll find it many times. A case of epilepsy. You'll go to the history. This patient was diagnosed with epilepsy, and recently, okay, he got 3 fits. Recently, he gets 4 fits. This is very important. This type of question is very important in the exam, because here they want you to dig what's going on, why this patient has fits now, why it's coming again. Here you need to catch that if this patient is changing his dose, non-compliant with his medication, is taking a wrong dose, he missed the dose, he's taking a new medicine or change his diet for which they have drug interactions. Okay. So you need to, sometimes it's just a diagnosis, even in communication or in history. It could be diagnosed patient with epilepsy and have recent fits. It could be another cause. Maybe have seizures and he developed something in his brain. Maybe he have seizures. I had one case like I was planning to prepare it for you, but I found it would be very tough. It was a patient with epilepsy, and then he has more recent epileptic fits because he's not compliant with his medication. And now he lost his consciousness twice in a different way. Okay, and have continuous headache. And this patient was subdural hematoma because he hit his head in the last seizures he was exposed to, and now this exaggerated his fits, and now he needs neurosurgery. And this is a very tough history case, but it can happen. And I'm sure if I bring this case to you, you'll do it very well. Give me 1 second, please. I should answer this. Question can come, so it can be a patient with non-epilepsy coming with non-compliance and this could be the case, just diagnosed, and could be just seizures, and you want to go and found it's epileptic. So you should go to epilepsy, okay, or get the other reasons of seizures. It could be any other reasons, PS, tuberous sclerosis, drug-induced, or whatever. The most common in the PACES exam, the most common are drug-induced epilepsy, tuberous sclerosis, and epilepsy. This is the most common. Add to it, the fourth one is hypoglycemia. They like to bring hypoglycemia as a cause of fits. The patient can have hypoglycemia as a cause of fits. So here you need a differential. I mean, you don't think that you should give a definite diagnosis exactly. Sometimes they give you that you reach a differential. You should give a good reasonable differential, and this is more than enough. I think after the 5th day of the course, you understand what I mean by differential. Differential does not mean to say a stupid unrelated diagnosis. So don't go and say it could be postural hypotension and it could be vasovagal. No, you can't say that. This is wrong. It's not a postural hypotension. It's vasovagal. So you can't. It's emotional or blah blah. Okay. So, but if there is no change in relation to the change in the position, it's not a postural hypotension. You can say, okay, sir, this is a syncope. It could be vasovagal. It could be seizures. It could be cardiac. It could be no. So what you did nothing. You just tell him the book. He is asking about the differential based on your finding, based on what did you find while approaching the case. Okay, so in this case of the man, you can say it could be carotid sinus, but considering his age because of the position, considering his age or her age, I would consider the possibility of TIA because of the presence of carotid berwee. Okay, I should consider the presence of any cardiac cause. So I would like to do carotid Doppler. I would like to do echocardiography for the heart. Right? This is how to talk as a doctor. Remember here, I want you to write a very big circle. All right, in a driving, climbing, swimming, cycling, dancing, sleeping, and bathroom door. These are points you should comment about in station 5, in history, in communication, when it is about seizures. You should advise regarding all of these. Try not to swim or cycle without supervision till we are sure what is going on. Even if it's still not yet, just advise him. Well, I will get a question. Should we inform DVLA about the first seizures? I'm not talking now about informing DVLA. I'm talking about advising the patient. We'll advise him about not to drive, swim, climb, okay, cycle, because any of these activity, again, Dr. Rana wanted again. Driving, climbing mountains, swimming, cycling, using a bicycle, or riding a bike. Okay? Dancing, because of the, this triggers like lights and high sounds. And sleeping, the lack of sleep, and bath door. Don't close the bath door. Advise him when you are in the bathroom, don't close the door, because maybe he will get a fit inside, hit himself, hit his head, bleed to death. So remember to talk. I think Dr. Nada will talk about these things, or she talk about that anyway. So you should have a hints about what the things you should talk about in this. Okay? You should remember again I want you to write about the triggers. You should know the triggers of epilepsy case, like lack of sleep, lights and screens, looking to screens, stresses. So you need to remember that. Okay? Then I want you to write some hints I want you to know about. There is an issue regarding the pregnancy and epilepsy. Okay, many issues about pregnancy and epilepsy. The first thing before pregnancy, to remember it while you are counseling a patient or in history. Before pregnancy, don't ask me when to put this. I want this knowledge to be in your head to use it whenever you need it. For pregnancy, all contraceptive pills failure, because when the patient was in anti-epileptics, this increased the metabolism of the heart or the liver of the oral contraceptive pills, because if the patient was cytokine B for 150, then it could be ineffective. So the patient will become pregnant while on anti-epileptic, and this is a horrible thing. So you should advise the patient to go to the OB/GYN doctor to use intrauterine device. What about lactation? For lactation, the patient on antiepileptics, they can lactate, except on barbiturate and benzodiazepines, because this make drowsy. The patient, the kid will be very drowsy, so barbiturate. But she can, and again, you don't need to give a definite advice regarding these things. You can just tell them you need to refer back to the doctor, to the OB/GYN doctor. But for now, she can, for your knowledge, most of the antiepileptics you can give lactation, except the benzodiazepine and barbiturate. Okay. Again, these are some tricks. Again, when you want to, the least toxic one is lamotrigine, which is lamictal. It's called lamictal. This is good for pregnancy. Not good. I mean, it is one of the safest. Okay, right. These hints, I don't know if you're writing or not, but when you are going to stop, never stop the medicine abruptly. You need to stop it over 2 to 4 months. Okay, stop it gradually. And there is some like barbiturate or benzodiazepine, because there is an addiction, so you should stop it on 6 months. But for the normal 2 to 4 months, and if the patient is on 2 medicine, you should stop it one by one. I mean, if the patient on 3 antiepileptics, don't stop all of them. No, the advice would be stopping one by one. Okay, all these items you can discuss in history. Maybe it comes as a concern. Maybe the patient will tell you, okay, I have side effects of this medicine, I'll stop them also. Then at least we will stop it one by one. Okay, if in communication you need to know what to discuss, what to talk about. So this some knowledge in order to be able to discuss it in the station. Dr. Gleich asking me drug-induced TS hypoglycemia. What is the fourth what? You mean in the exam epilepsy? Epilepsy itself, just primary epilepsy. Okay, we found no reason. It's just an epilepsy. When to stop it? You can stop it in 2 years. If 2 years without fits, you can stop it. Okay, when I have a question now. When to start anti-epileptic medications? When to start it? Anyone have an idea? When to start it? Not after first seizures. This is Dr. Gleich. Dr. Rahman said second fit. Dr. Rana said second fit. Dr. Rashid Islam said repeated seizures. Okay. So I will tell you the condition where you are going to start the medicine. First of all, if there is 2 attacks, yes, you are right. 2 attacks. This is the first. The second, if it is 1 attack plus. The first thing, if you remember this from the first part from RCP, If another fit is not accepted, the patient say, "Oh my God, if I have, I don't want to get it again. I feel my son have blah blah blah." So everyone. So first of all, if there's one seizure and another seizure is not accepted because you're telling there's a possibility, you know, to start me on medicine. I don't want to face that again. I don't want my son to face that again. This is the first thing. The other thing, if there is a focal deficit, if the patient have fits and have a weakness on the left side, have dysphasia, have also whatever. So if there is a focal deficit, then the third thing, finding in imaging or EEG. So if there is a finding on the MRI, if there is a finding in EEG, we will start medicine after the first seizures. You got it? What, Dr. Rana? President? President what? What do you mean by president here? What? So, okay, this is the case. When to start the medicine, you start after 2 attacks or you start with 1 attack when another seizure is not accepted, focal deficit, imaging, and EEG finding. I think nothing else. We need to folic acid. Remember to give a patient on antibiotics, folic acid, especially if there is a risk of pregnancy. Okay? Okay. So to summarize, I got the patient. I received the patient who has a. Just a second. To summarize the possibilities for the cases, that it could be a patient who is coming with dizzy spell, and for dizzy spell, you need to go through these circles I showed you before. You need to see before, what you were doing, what did you feel? Yes, during and then after, and depending on these, you will search your found your diagnosis. Here, I will show you that there is a syncope, and there is vertigo, and there is epilepsy, and there is TIA possibility. Sometimes it's just TIA, there's weakness before it. There's you wake up with some heaviness. It doesn't go with any other diagnosis, so I consider TIA. I want someone to answer me how to diagnose the vasovagal, other than clinical. Is there any way to do something to diagnose the vasovagal? Yeah, tilt table, right? It's tilt table. In tilt table, they put the patient in a position, and then they put him in another position where they decrease the perfusion to the brain. Well, if the patient lost his consciousness or becomes super dizzy, if they put it in 60 to 70 angle, if he lost his consciousness or to become very dizzy, this will be possible. Okay. Okay. So then you will go to this page to search, ask about the postural hypotension and its differential hypoglycemia and cause of Addison. Okay, doctors. Hello, doctors. Please confirm that everything is clear. Then we will move to the next case. And tell me, please, if you really see this is helpful. I mean, now I know this is long, as I said 100 times in this part. I know it's long, but it's important. It will build your idea about these type of cases. So you have your approach, you have your pathway to deal with these cases. A lot of details, but eventually you will collect all of that. Once you start to implement, you will notice that you don't need to use all these, but at least you now understand the principle of these type of cases. The nightmare of these type of cases will be easy. Okay, so Dr. David said, thank you. Clear material, Dr. Ibrahim. It's very helpful, but no man. Okay, this is 47 years old lady referred by her GP for dizziness and she's 37, sorry. 37-year-old lady referred by her GP for dizziness and weight loss and rash. Okay, you have 2 minutes. Once we can start, please tell me. This station 5, you need to examine the patient. Everyone in the white paper, please write your approach, write what you're, just make your plan, what you're going to ask, what you think about.
Yeah.
Let's start, doctor.
Okay. Good morning. I am Dr. Osman. I would like to confirm that you are Karima Ahmed.
Yes, doctor.
You are 37 years old.
Yes.
Ms. Karima, I received a letter from your GP stating that you are troubled with dizziness, weight loss, and rash.
Yes.
Can you tell me more about that?
Yes, doctor. In the last 1 year, I noticed that I feel dizzy. I feel dizzy many times. Sometimes I'm going to faint by this dizziness, and I need to close my eyes and be supported. Otherwise, I'll fall down. This also was treated with weight loss. Although I'm eating well, not very well, but I'm losing weight. Okay. And also, I noticed recently that I have an itchy rash in my arms. So, can you help me with that?
Yes, sure. Can you is it faintness? You feel like headedness as if you are going to faint?
Yeah.
You lose your consciousness?
Naturally, doctor.
Okay. How does it start? Is it gradual or sudden?
It's gradual. I mean, attacks coming over the year.
This is the first attack, or?
No, I have many attacks over the year. I told you.
How many attacks?
Maybe 5, 6, 10. I'm not sure, but it's recently it is more repetitive.
They are similar or different from each other?
Yeah, I think they are similar.
Okay. What were you doing before the attacks?
I'm not sure, doctor. What do you mean?
For example, were you exercising or
No,
eating?
no, doctor. Not exercising, not eating.
Did you notice that it's related to movement of your head or your neck?
No, doctor.
Okay. Were you in area that is crowded?
No, doctor.
Okay. Okay. Do you felt any symptoms before the fainting?
No, nothing specific. Doctor.
Like didn't you feel chest pain or racing of your heart?
No,
Any weakness or heaviness in your tongue?
no,
Any sweating or hunger pain before the attack?
no.
Do you feel this attack occur after changing position from sitting to standing?
Yes, doctor. I noticed that while I'm praying, when I'm changing my position, usually I feel this dizziness, and sometimes that's why I start to pray while sitting on a chair.
Okay.
Yes, usually I'm feeling that I'm going to black out when I'm standing from sitting or getting up from the bed.
Okay. Anybody noticed that during the attack your skin color changed, becoming pale or blue?
Nobody
Example.
told me that. No, no. My husband see me like that, and he didn't tell me anything happened.
Okay. Any shakings when you
No.
are unconscious?
No.
Sorry for asking you that. Did you lose control of your urine or
No, doctor.
did you injure your head
No.
or your head?
No, doctor. I didn't fall down.
Okay. For how long this last?
I think it takes me less than 1 minute.
How it ended? Did it end
It
spontaneously?
ends by its own, doctor. I just stand for a while. It ends by its own. I mean, I just stay for some time, then I feel some improvement.
Okay. And after that, did you feel any symptoms like weakness or
No, no,
feel sleepy?
No.
Difficulty of speech?
No.
Okay. Can you tell me about your rash? Can you see your rash?
yes.
Where is the site of rash?
What? Arm, my arm.
This is only area or another site?
Yeah, it's in a different area in my body, and it's very itchy.
Okay. And for how long this rash?
It's for since it's 2 or 3 months.
Is it oozy?
No, just like the vesicles, itchy vesicles.
Okay. What about your weight loss?
Yes, doctor. I lost about 9 kilograms over the last year.
I'm sorry for that. Is it intentional?
No, doctor.
Do you have any headache?
Sometimes, doctor, yes, I feel heavy.
Okay. Any vision problem?
No, doctor.
Any pains and needles on your hands?
No.
Or any shortness of breath?
No.
Any joint pain?
No, doctor. Sometimes.
Any fever?
No, doctor.
Any lumps and bumps?
No.
Any loss of appetite?
A little bit sometimes, doctor. I feel, yeah, I have some feeling sick, and I'm throwing up frequently.
Can you show me your drug list?
I'm not taking any medication, just Dr. Cream for this. That's it. 2 minutes remaining.
Can I know your concern?
Yes, I want to know what's going on, doctor. Why I'm feeling dizzy, why I'm losing weight, do I have something serious? And what about this rash? Is it treatable?
Okay, before that, I just would like to examine you. I'd like to examine the heart.
No need, doctor.
Mm.
It's normal. What else you want to examine?
The abdomen.
Tummy pain. There is some pain, parambilical pain. And there is a scar. There is a scar of previous cesarean.
Okay. And oral cavity.
There is pigmentation.
Any loose motion?
No, sorry. There is still 1 minute. Sorry, this is on this one. Okay, continue.
Okay, any loose motion?
Yes, doctor, I have a loose motion. I have severe loose motion.
Okay, Mrs. Karima, from this discussion and your examination, I think that you have a problem with your glands. It's not secreting adequate hormone, protein, special protein that is called hormone, and this is leading to your symptoms. And I think it is due to defect in your defensive system. So I need to do we need to do some blood tests and imaging. According to that, we'll treat you. Is that okay?
Okay, doctor.
Do you smoke, Mrs. Karima?
No.
Do you drink alcohol?
No.
Okay, what do you do for a living?
Yes, I'm a teacher.
Okay, how does this affect your life and your work?
This business. So every time I'm moving in the class, I'm taking a lot of sick leaves because of that. Time finished, doctor. Thank you.
Okay.
Now, questions, doctor. What's your differential diagnosis?
Potential is autoimmune disease, like Addison disease, with malabsorption syndrome.
With malabsorption? What type of malabsorption?
Celiac disease.
Celiac. Okay. Did you ask about anything related to food?
No, I didn't ask.
You didn't.
Because the doctor is very strict.
Did the patient have anemia or not?
I didn't check the eyes or the symptoms even.
Okay. Good, doctor. What's the relation between the Addison disease and celiac disease in association?
Both of them are autoimmune, and usually autoimmune diseases come together.
Yeah, they can come together. Correct. How would you investigate this patient?
I'll do antibodies for celiac disease, antibodies, and also I'll do CBC for looking up for malabsorption, anemia like this, and I'll do also imaging, CT scan, see his adrenals.
Okay. Okay, doctor. What else you want to examine in this patient?
Thyroid.
Thyroid, good.
Yes.
Yes, good. So do you want to check the blood pressure sitting and standing?
Yes, also high. Yes, this is important.
Okay, the time finished. Thank you. Okay, scores. Doctors, give Dr. Afra a score. You know what? I like the name Afra. It's a nice name.
Thank you.
Although it looks very weird in English, but in Arabic it looks a very used special because I'm waiting for a doctor something about that. Okay, so they give you okay. I need all to give her the score. What? How much you give yourself, Dr. Afra?
I don't.
You felt stressed?
Yeah, this is my first time.
Yeah, dry mouth.
Yeah.
Dry mouth and tachycardia, right?
Yes. And the time is very restricted. This is my first time to practice.
One of the things I want you all to do when you go to your I think most people go to clinical courses to do for station 1 and 3 and see more cases in live and do the practicing. One of the most important things I want you to do is the mock exams. Please, doctor, do a lot of mock exams before your exam, because whatever you will do, whenever you are in the exam, you will feel a little bit struggling if you didn't see the patient, examine, and utilize the time. You need to do that in the live patient. So mock exams is very important. Whether you go to Dr. Ramadan, whether you go to Dr. Ahmed, wherever where you're going, please do 2 or 3 days of mock exams, which is nothing. Only you will go and see patient and give your comment. Even for station 1 and 3, you will check the patient, give your comment. You will try the station 5. It's not enough to look at the patient fundus and see what's there. I want you to decide when you are going to look at the fundus, how much of time you will consume while looking to the fundus. Okay, how much you will present your finding in the cases. So this is very, very important. So please mock exam. Nobody go to. I know that you all get your place in the UK. The doctor will apply for UK today. They give you the name of the hospitals. So please, whenever you're going to take your clinical course, please ask for 2 or 3 days mock exam, because these days not for the overseas. Usually when it is Egypt exam, you will find mock exams with all of these tutors. But these days you may find no mock exam with Dr. Ramadan or Dr. Ahmed. Okay, or Dr. Ramadan. So ask them to do mock exams for you, please, please, please. Okay, this will make a big difference in your results and in your performance. I want you to implement all. You will feel the difference when you go to this clinical part after our course, because you have all this background. You'll be implementing that. You'll know the skill of implementing that on the real case, in the real life. So if you compare the difference when you're going to these courses without any background, and when you're going now and know what to ask and what you are expecting to see and what you're expecting to examine, so it will make a big difference. If you didn't do that, you will feel that big deficiency in this. I'm advising everyone who has access to Egypt to go there and take all of these courses. It's way cheaper than the UK courses. UK it's 2 days or 3 days, and it's not enough. Okay, for Egypt you will spend one or you will take 1 or 2 weeks, and you will see every day about 10 or 15 cases, and you'll practice what you learned with me for station 5 and for all the cases you face. Then and you'll practice for station 1 and 3. So please remember, there's not only cases. Even if you want to Ramadan, tell him to make to give you 4 or 5 cases every day to do mock exam. You will go and examine the patient and present it yourself away with the group. So you'll try how you're doing that and what the things how you're utilizing your time. Very important. Okay. My opinion, Dr. Afra, you did very, very well. Okay, actually, there's some comments about the performance again. For the first time, it's more than perfect. You got the correct diagnosis, but you are wasting a lot of time. Do you agree with me? I mean, there is a lot of stuff to improve in your performance, right? In station 5, it's like a race. It's a race. You need to be very fast, and you start examination very late. So you need to start examination a little bit earlier. So once you start to examine this patient, you look at the rash and you see the scar. So we're done, right? So as I told you, simply you went through the question of what before, what during, but after. I did that very well. I don't want all the details. Once you catch something, it is enough. You don't need to ask every one single word at this page. Okay. Then you went to the postural hypotension. I would rather if you ask also the hypoglycemia with that, the hunger pain and the excess this stuff. Then you confirm that it looks like you asked it early. I want you to ask about the loss motion and tummy pain and the vomiting and the nausea early. Then you confirm that this is Addison. You have pigmentation, tummy pain, vomiting, nausea, weight loss, loss motion. What else you want? In the presence also of this rash, you will think about some association like celiac disease, and I agree with you. This is dermatitis herpetiform, itchy, and it is characteristic in each feature. So with the loss motion that can happen due to Addison, it can happen also due to celiac disease. So go and confirm your diagnosis again about the flushability of the stool and about the relation between the pasta and the bread with the loss motion. You agree with me? This question you can ask. That's why how to utilize the time to the point. In station, it is not a history. It is station 5. You need to be very fast. You know. So with this video, just now you confirmed your diagnosis and you found the association. Okay, then you will say that you should say that I'm going to check the blood pressure sitting and standing. This is the first thing you'll ask for. Okay, then you look to the eyes for anemia with malabsorption, and then you will look for the mouth for the pigmentation. Okay, and signs of anemia. Okay, then you will go and look at the scar. So I will show you on the next slide how to do that. Then you will do the management plan. So you did very well. I want you to, again, I want you to be more conversational. Okay, in the conversation, but you did that, not bad. And the speed. The issue with you is the speed and when to start the examination. In station 5, it doesn't matter what comes first. So if you see that you examine the patient and you see something and you start asking questions, in this stage they will not cut marks for that. So whatever what will help you in station 5 to catch the diagnosis, do it. So if looking to the rash very early, if asking about social history very early will solve your problem, go ahead and do it. Okay. Again, here, if you increase your speed, you'll have time more. It's more important about more than having asking about smoking and drinking, asking about the past history of hypertension, of diabetes, of previous admission and previous surgeries. So it's travel history for HIV, for example. Okay. So anyway, I mean the structure. Again, the structure is very important. You asked about the impact. You give a good differential diagnosis, including the correct one. Okay. When you are asking about the differential in this case, you would say, okay, it could be Addison disease with celiac disease, it could be vasovagal dizziness, it could be anemia causing the dizziness, it could be dehydration with the loss motion. You agree with me?
Yeah.
Okay, so that's it. But anyway, your score in this case, not less than 22. It can, based on the examiner, it could be 24, it could be 26. If he's a nice one, he may give you a full mark because you reached a good diagnosis. And you should. That's why I'm telling you, you need to practice that on a real patient, because you don't need to examine everything in station 5. Okay, because the time will not allow you to do that. Okay, Dr. Afra?
Yes, thank you.
Did you learn something from this case?
A lot of things.
I like to catch the case. Very smart to catch the relation between the two autoimmune diseases. Okay, thank you. So I'll close now your mic and I'll go to discuss the case. Okay. I will examine the Dr. Imam. You will see that Dr. Imam now. Yes, the cesarean scar. She see the cesarean scar. She saw the pigmentation of the cesarean scar. This is what gave her the answer for the Addison. It's pigmentation of the scar. This is what helped to see that the pigmentation will be more obvious on the scars. Okay. Here in Addison disease, this slide very important. You will receive it in the post lecture. You will ask about using steroids. Very important. Ask very early if you are taking any medicine called steroid. Because with steroid, you may have Cushing and you may have patient with Addison due to stopping the steroid. Common scenario in the exam. Okay, there will be weight loss. You ask about pigmentation. You ask about abdominal pain and nausea and vomiting. You ask about the changing of the dizziness when standing and changing position. You will ask about the symptom of hypoglycemia. You will ask about thyroid disorder. So you will ask about weather preference. This is answer your question, Dr. Imam. You are asking for that because the polyglandular autoimmune. Okay, so you will ask about weather preference. Okay, weight gain or weight loss, constipation, for example. And here, sometimes in presence of two conditions, there could be balance of this, but weather preference will be very important in that. Then and the menstruation. Then the vitiligo and pernicious anemia and alopecia as part of the autoimmune disease. You ask about skin color changes. Okay, and you will ask also about being more pale than usual or hair loss. Then you will ask about risk factor for HIV and for TB, and you know how to ask that, about sharing needles and about unprotected isolation, about exposure to patient with coughing or coughing out of blood, all this stuff. Okay, so you need to practice to ask these questions very fast. Okay, you didn't need to ask all this in station 5, but you need history to ask this question. Then you will move and start examining the patient, and you can ask during examining the patient. You will look to the hands. So in the hands and the crease, you may say pigmentation and pallor as well, pallor and pigmentation in the creases. Okay, signs of anemia. There will be an oral cavity. I'll look for pigmentation. I'll look on the scars for pigmentation, and I'll look for the nipples and areola for pigmentation in Addison disease, or very pale areola, for example, in the panhypopituitarism. Then a blood pressure line and standing. Okay, for orthostatic hypertension in the abdomen, there could be pain. Okay, and we need also to exclude hemochromatosis for the pigmentation and the weakness and dizziness. Blood sugar, I will ask to test the blood sugar, very important. Sometimes there is low blood sugar. I will offer to examine the thyroid, no time to do that, but I will offer to examine the thyroid gland, and they will look at the skin to check for vitiligo and pallor and alopecia. Okay, in this picture you will see bronze pigmentation of the skin, change, disturbance in body hair, hypoglycemia, postural hypertension, weight loss, GI disturbance, and weakness. Adrenal crisis, there is profound fatigue, there's dehydration, vascular collapse, and low blood pressure, renal shutdown. Okay, low serum sodium and high serum potassium. Okay, so this is an Addison disease. This slide is very important. They solve the problem. You know, simply this. I tell you what to do with Addison. Addison is common in the exam, especially in the history cases. Investigations, you need to do basic investigations, including for sure blood pressure and electrolytes and for blood count. Basal test, we are doing the 9 AM serum cortisol, usually low, and 9 AM ACTH high if primary adrenal insufficiency. So when the patient has a problem in the adrenal gland, the ACTH will be high, and this is causing the pigmentation. Dynamic test, short synaptic test, and long synaptic. They will not ask about the details of that. Test for the etiologies. Okay, if it's an autoimmune, I want to do anti-21 hydroxylase antibody, thyroid function test for association, CT, chest, abdomen for TB and for masses, adrenal masses, this stuff. HIV test for if there is a risk for that. The treatment, oral hydrocortisone. If not effective enough, we are moving to stronger cortisone, which is fludrocortisone. If postural hypertension is resistant to hydrocortisone, treatment is for life. The patient should know that she will be on this treatment for life. Okay, requirements increase during severe illness and surgery. So if there's a history, you should do that. If it is a communication, it is counseling for a disease, it's very important to go through all these advices regarding Addison, because you may have a case of counseling, okay, for patient with Addison disease or newly diagnosed Addison disease. So you need to advise for the bracelets, you need to advise for the steroid bracelets, okay, or carry a cards or carry a ampoule of steroids, okay, vial of steroid in your pocket because you may have this crisis. Okay, so it's all this golden tips for the treatment. You need to mention, you don't have time to do that in station 5, but you will have time to do that in history or in counseling and communication. So it's very important. If you didn't do that and give this advice in case of Addison in the history, you will lose a lot of marks. They will not expect it's difficult to get Addison, but it's difficult to continue with giving everything should be regarding Addison. The most important thing is the adjustment of the dose with stresses and infection and surgeries. Treatment for the crisis is triple S, steroids, sugar, blood glucose, giving glucose, and saline as well. Okay, so this is for the Addison. What are the polyglandular autoimmune syndrome? There's two types. The first one is Addison disease with mucocutaneous candidiasis and hypoparathyroidism. Okay, then type 2, it's Addison disease, either it could be with diabetes or hypothyroidism, maybe associated with pernicious anemia, celiac disease, hypogonadism, and primary sclerosis. So in this case we discussed today, it could be type 2 polyglandular autoimmune syndrome. Okay, although you shouldn't mention that because you catch the two components, but I mean it's one of when these cases come together, we call it polyglandular autoimmune syndrome, and you need to search for other component if it is there. Okay, that's it. This slide also is good for the differential diagnosis for tanned skin. Remember the word spare. The word spare. The first is sun exposure. The second is pregnancy. The third is Addison disease and acanthosis nigricans. The R for renal failure patient and liver failure as well. The A for excessive iron and copper. Okay, patient with hemochromatosis or Wilson. Then the D for drugs: monocycline, amiodarone, phenothiazine, and antimalarial hydroxychloroquine. They all can cause tanned skin. Just to remember it as differential. Okay, I want everyone to give me the okay that he got the case and you found this helpful. Give me the okay for Addison. Okay, did you like the slide of Addison? Good. Okay, great. So this will be the slide that you can study from instead of going and searching that in books. That's why, a lot of slides will be very helpful while preparing, better than going to them, especially in these cases. So I hope you're lucky and you have some of these cases in your exam. Now, voting for two things. You know what? No. Oh, no. Let me tell you what I'm going to do, because we have more cases for the dizziness, but I will give you an idea about them, okay? And because we want to move, it will be the same topics, but it's more practicing, but we have more topics to discuss today. Do you agree with me that I will just go through these cases and tell you what was the trick in the cases, so we can move to the other topic, because we have many important topics today, okay? And they need all your concentration. We will discuss a lot of things about the eye, we will discuss a lot of things about the visual field and this stuff. So do you agree with that? Give me your opinion. Okay, Dr. Afra said okay, Dr. Shazia said okay. Okay, good. And Dr. Wafi said give us the trick and proceed. Yes, I agree. So I agree. Okay, Dr. Mina, okay, Dr. Sahar, good, very good. So there is one case, this is the case in the Rider book, and it is a patient with, the patient was 25 years old man who was collapsed, okay, came by ambulance, and he was collapsed in a marathon. Okay, so the case here, what you are expected to do the same, patient collapsed, so you need to search. So here you're different when you ask about before and during and after. This happened during running, and when you take a history with the patient, you will find that the patient didn't drink enough water. So it was about the stress and about dehydration and about the athletics. Okay, so your differential will be between vasovagal and between orthostatic and plus or minus cardiac. But there's you need to ask about the family history of sudden cardiac attack, something like HOCM. You need to ask about chest pain, awareness of heartbeat, and you need to ask about stresses and good hydration and good sleeping and fluid intake before the marathon. So assembly it will be the same principle. it will be the same principle. He didn't hit the floor. Okay, so nothing new in that, but you need to consider these differentials. Vasovagal with the stress and with the effort. Okay, then with the marathon, and orthostatic because of dehydration, excessive sweating during running, and cardiac because this is considered during exercising. So HOCM could be considered. Aortic stenosis could be considered. Okay, even heart attack could be considered. So this needs to be dual differential in such case. Okay, and this was the case. Please, the doctor was writing on the wall. Don't do that. Please. Okay. So and the other case, it was one patient. I don't know if it's here or not. No, there's another one. Then there's another case also. It is in rider on 180 case. This was a patient 75 years old, and he felt dizzy while he was in the restaurant and he was eating. He was there in the restaurant ready for eating, and then he lost his consciousness. Okay, within he felt dizzy and he collapsed for 2 minutes. And when you ask, he will tell you that this happened while he was changing his position from he was standing to go to the restroom. Then he felt that. Okay, then you need to consider. You can't just say here this is postural hypertension only because the patient also is 75. So you need to exclude. The case is you are the ST2 acute medicine unit, and you are asked to look to Mr. X, whose history of collapse. He came to ER, collapsed in the restaurant while standing to go to toilet. Bystander noticed some twitches in his arms and leg, but he back to normal within 5 minutes. So you need to consider the TIA. You need to consider all these, but eventually, but this is not fits. They just see abnormal movement, but it was not a clear fix. Okay. I didn't mean that. I don't know. I don't know what it is, but I did. Okay. So that's it. Yeah, no problem. I'm just kidding. So in this case, again, simply you would catch that this in the history of this patient, the old patient, he is in alpha-suzine, which is alpha blocker, and he's on thiazides. So all these are risk factors for postural hypertension. Patients with benign prostatic hyperplasia and they are on alpha blockers, and patient on diuretics, they may have postural hypertension. So you need to catch that in the drug history of the patient, very important. And you need to consider also the same slide. You will use the first slide, so you will catch its postural hypertension. You will exclude the cardiac, you will exclude the TIA, you will exclude the hypoglycemia. You will put that in your differential, and eventually you will put in the top the postural hypertension, but you still need to exclude the cardiovascular and the vasovagal and the TIA because considering the patient is 75 years old with risk factors like hypertension. Okay, are you okay with that? These were the cases. Read them, please. The first case is Rider 3. The second case, Rider 3, page 208. Okay, please read it. And the first case is Rider 3, also 188. You received the book. I sent you Rider on the group, right? I sent it. Correct. Please confirm in the chat box that you received Rider and Rider 3 and Rider 2 on WhatsApp before. Received. Okay. So Dr. Afra said you received it. So it's there. Anyone, if you don't have it, please. So just download it and check page 208 and page 288. Okay. Okay. So, Dr. Ibrahim, Ibrahim Muhammad.
Yes.
Assalamu
alaikum.
How are you, Dr. Ibrahim?
I'm fine.
Where are you from?
From Sudan.
Yeah. I'm missing the Sudanese friend. I have a lot of friends from Sudan when I was in Gulf area. I really like all of them. But I have friends here also from Sudan. So I hope, inshallah, the best for your country, inshallah.
Inshallah.
With your revolution.
Okay,
Dr. Ibrahim, are you ready for the case?
Inshallah, I'll try.
Good. Okay. So this is a patient. It's a simple one, inshallah. This is a patient. You are the senior house officer in acute medicine clinic. A 26-year-old man present with a 6-month history of visual deterioration. Okay. Please examine. Please check and examine. This is patient 5. He is a driver.
Okay.
Okay, Dr. Sharif, Dr. Sharif saying I received Rider. You're supposed to receive to find it in the WhatsApp group, Dr. Sharif. Let me check the WhatsApp group. I sent it in the media. Did I send it in the WhatsApp or in Telegram? I can't remember actually. Maybe on Telegram. Okay, I will send it for everyone. I will put it in the group. You can send it in WhatsApp, right? I mean, WhatsApp can generate the 45 megabytes, right? Anyone expert in that? Because usually I'm sending on the Telegram. I think it's loading, so it will be there. Okay. Khiana, this is Khiana. You received from another group. You will receive it on the WhatsApp group now, no problem. Okay, so Dr. Ibrahim.
Yes, with you.
Okay, let me start the timer. So this is station 5 case. Let's start.
Hello.
Hello.
I am Dr. Ibrahim, one of the doctor in the medical clinic today. Are you Mr. Philip?
Yes.
And you are 26 years old.
Yes, I am.
I received a letter from your GP stating that you have a problem in your vision since last 6 months. Can you tell me more about this?
Yes, doctor. I noticed that gradually I'm losing my vision. My vision become more blurred. Okay. And
I'm sorry for this.
yes, thank you, doctor. And I had an accident because of this problem in my vision.
I'm sorry for this again. Can you tell me this is the first time to have this blurring of vision or before?
Yes, doctor. In the last 6 months, this started. Before I was fine. I have no problem in my vision. I'm not even wearing eyeglasses.
Yes. Is it? Can you tell me this is related to peripheral vision or related when you are reading newspaper or books?
You mean side vision?
Yeah, side vision.
Yes, doctor. I think so. It's also it's more than side vision.
I'm sorry for this. Can you tell me is it associated with any pain while moving your eyes or?
No, doctor, nothing.
Okay. Is this blurring vision, is it all of the day or occur certain time of the day?
It's all the day, doctor.
Okay.
Yeah, but it's worse when it's getting darker for sure.
Okay. Can you tell me does this blurring vision associated with headache?
Headache? No, doctor.
Okay. I need to ask you, do you have any problem like chronic disease, diabetes, or any hypertension?
No, doctor. I have no hypertension.
Okay. I need to ask you, do you have any previous history blood clot or any family history of blood clot?
No, doctor.
Okay. So can you tell me also, show me your medication list?
I'm not taking any medication, doctor. I'm 26 and I'm healthy.
Thank you. Can you tell me, do you have any weather preference and any problem in your joint or your eyes other than this blurring vision?
No, doctor.
Okay. May I examine you?
Yes. What do you want to examine?
I need to check for blood sugar and dipstick,
No.
blood pressure and dipstick for sugar.
No.
Okay. I need to examine the visual field and.
Visual field. There is some affection in the side visual field.
Okay. Okay. Also, I need to examine the back of your eyes.
Yes. So you need to do fundoscopy?
Yeah.
Okay. This is the fundus.
Okay. Thank you. Okay. I need also to ask, do you have any long-lasting disease in your family or any disease in your family?
I'm not sure, doctor.
Okay. So can you tell me what do you do for a living?
I'm a driver, doctor. I'm a heavy good vehicle driver.
Okay. Can you tell me how this problem in your vision affect your job?
What do you think, doctor? I'm a driver, doctor. So
Yes, I'm sorry for this question. I know this must be difficult for you. And can you tell me with whom you live at home?
I'm living with my girlfriend, doctor.
You have any support there at home?
What do you mean by support, doctor? I'm supporting.
Did she supporting you, your girlfriend?
Yeah, like all the girls, doctor.
Okay.
If I become blind, she will leave me for sure.
I'm sorry for this. So for that, try to do my best to help you. Can you tell me, do you smoke or drink alcohol?
No.
Okay.
2 minutes remaining.
Okay. Can you tell me what's your concern at this moment?
Yes, doctor. I want to know will I be blind, and if I can still driving. Okay. And the last thing, what if I have kids? Will they have the same problem in their eyes? Is it something that I can hurt to my kids?
I'm sorry for this. I need to solve your concern first one regarding driving. I need you to stop driving.
I'm going to be blind, doctor.
Yes, from what I take from talk to you and what I examine you, that this you have a condition that called retinitis pigmentosa, and that it's running family. I'm afraid to tell you that even your kids may have this disease, but we can't predict this inaccurately. Other thing, we need you to stop driving. Stop driving. Meanwhile, assessing you, and also we need to refer you to ophthalmology, eye doctors regarding this.
Okay.
And what is can you tell me what is the last concern? The third one?
All my kids, would they have the same problems? If,
Yeah, I told you this. Maybe running family, these types of diseases.
so you give me any treatment for that, doctor?
So yes, when I told you this disease called retinitis pigmentosa, in which the back of your eyes affected, that lead to this deterioration in vision, and even more at the night time. And for this, I will refer you to multiple group of doctors. One of them, the eye doctors, so as to confirm this diagnosis.
Time. Finish. Okay.
Okay.
Questions? What's your differential diagnosis, doctor?
Differential diagnosis is the retinitis pigmentosa on top of this, and also could be a pan from, for example, pan what I call photocoagulation of the retina. Pan
Did the
photocoagulation.
patient tell you that he has any surgery or any procedure to his eyes?
This is against yes, it's not diabetes and no surgery before.
So this couldn't be one of your differential.
It's a remote one, maybe. Yes.
Okay, the patient's not diabetic even.
Yes.
Okay. Could the retinitis pigmentosa be by its own and can be part of syndromes, right?
Yes, possible. Could be as a part
Do
of
you know any of
syndrome.
these syndromes?
Yes, Usher syndrome,
Mhm.
and abetalipoproteinemia,
Okay.
and Prosson disease.
Okay. Okay, doctors. What else can be a cause of gradual weight loss?
Gradual loss of vision could be, as I told, chronic disease like diabetes and hypertension can cause gradual loss of vision.
Yeah.
And also some disease like neurological disease like multiple sclerosis
Yes.
cause gradual loss of vision.
Some medication can cause it, and some.
Yes, possible.
Okay.
Medication.
Okay. Thank you, doctor. Time finished. Score, please. Give Dr. Ibrahim his score. The doctors that are going to pray, you can go, but remember every piece, never miss it. When you come back, once it's ready, and Dr. Ahmed will send it to you, please watch it today, because the topics that's coming, and once you finish the prayer, come back, and continue this, because we have a lot of things about the eye today. So you need to know the eye stuff, and you need to ask your question. Okay. So, okay, so most of them give you, Dr. Ibrahim, 24 to 26. Are you satisfied with that?
Yes, this is a big score, I think. I'm not feeling did well.
You know, you did well. You will reach the correct diagnosis. You just need more confidence. Okay, and you need to know more information, or to be more organized, I mean, right?
Yes, okay.
And you didn't need to ask about my relation with my girlfriend. So,
okay.
like, if she's supporting me or not, this will not make a difference for you. Okay, so I mean,
because someone blind, not seeing, need someone to
with whom you are living is enough, because some questions it will be time wasting enough. So yes. Will support you? I don't know if she'll support me or not. This is the first time I'm coming to you, so don't let me go and you don't increase my worries. I mean, this is the first check, and you're telling me about the disease, so you can just say, do you have any support or whatever? But I mean, don't waste the time in this stuff. But again, here, this is why I'm saying the algorithm is important, and what you are discussing here is important, because you know how to look more professional in the station. You agree with me, Dr. Ibrahim? So you reach the diagnosis, and you are confident that this is the correct diagnosis, but you don't know exactly if what you are doing is the correct thing and the perfect thing, or there is something missing in this case, right? You get the correct diagnosis, you make the examination, but you did a very big mistake, which is looking to check the field of the patient before the visual acuity.
Visual acuity first, yes, sure.
You can't examine the field before the acuity. This is a big problem. The examiner he will start writing immediately once you do that. He will write that he examined the field before the vision. So you need
sometimes to subconsciously, because running of thoughts.
Yeah, I know, but I mean, everyone needs to take care of that. Please don't examine the field before if the patient can see. You can't examine his field. This doesn't make any sense, right? So yes. I want all of you to watch how to examine the eye on the YouTube, and you will do that in clinical course. Whatever you want to know how to examine, because I can't do that online, and I don't want to waste the time by playing some videos. I will be playing some videos for examination in the neurology station, but usually you will learn how to do that. But don't go to a clinical before watching the videos for the steps of examining the eye, because there's examination of the field, there's the shape, there's many things you should know how to do that. Okay, but the most important for me is the approach for the blinding of vision. Don't you think it's very important, Dr. Ibrahim?
Yes, approach is important. Save time.
Yeah, and it is a very wide differential. So again, something like that's why I'm considering the 4th day of Station 5 course as a heavy day, because it includes 2 of the most common and heavy topics. One of these are the syncope, and the other is the eye problems, and the blinding of vision, and including the field problem, and including the double vision. They are all, and the ptosis. They are all very important topics, and it's very tough to study it by yourself. So the course make it way simpler. Okay, so just give me a second, then we will start the demonstration of this part. Just a second. Mean by blinding of vision? Maybe he will say loss of vision. Okay, maybe he will say blurring. Maybe he will say size. Maybe he'll give you some. Just a second. Mean by blurring of vision? Maybe he will say loss of vision. Okay, maybe he will say blurring. Maybe he will say size. Maybe he'll give you some answers that help you. Then I want you to ask these questions fast. As usual, I told you I'm not expecting you to know this by heart now, but after a while, after practicing that, it will be very simple for you. You will ask the most important 2 questions first. Is it gradual or sudden? And this will take us to the right side or the left side of the algorithm. So it is gradual or sudden. Is it temporary or persistent? Because temporary or persistence is giving a different diagnosis. Write in the chat box, please, doctor. What do you think could be the causes of temporary blurring of vision? Temporary blurring of vision. Give me some answers on the chat box. Some causes of temporary blurring of vision. Dr. Samah said hypoglycemia. Dr. Samia said amaurosis of gas. Okay, Dr. Samia said amaurosis. Dr. Samah said glycemia. JSA initially. Okay, TIA. Yes, I'm waiting for that. Dr. Farouk said multiple sclerosis. Agree. Migraine. Agree. Okay, genital arthritis. Agree. Diabetes. Agree. Yes, exactly. So if the blood sugar is very high, okay, you may find there is a blurring of vision that's coming temporary, and then when we control the blood sugar, the blurring went away. The MS, the patient sleep and wake up by blurring of vision in the relapse and remission. Then after 1 week, okay, he has a remission and he's fine. After 1 month, after 2 months. So the question about is it temporary or persistent? Because many candidates just think this question will be about TIA and stroke. But I like your answers. Your answers are for all the causes of the temporary and persistent. What about the persistence? It could be eye trauma. It could be eye tumor affecting the eye. It could be some permanent damage to the retina, some permanent damage to the cornea. So whatever. Okay. So gradual and sudden is very important because it takes us to the right and left side of our algorithm. Temporary or persistence is very important as well. First time or recurrent. This is related to the previous question, associated with painful or painless. So if there is pain or not, distal or near vision, double vision or no double vision. Actually, these 3 questions looks good. You need to ask them, but actually it will not change your decision very much unless the double vision is important because it is usually related to the weakness of the muscles and sometimes the asymmetrical movement of the eye, which is related to many diseases. So double vision will be very important to ask about. These 4 questions are different. I put them red because they are related to something. Okay, when they are together, answered by yes. When I will ask about the central vision and peripheral vision, is it affecting the central or the peripheral vision? Is it more at the morning or more at the night? So you will find a patient telling you that I noticed that my eye problems are more at night because while I'm going to jog with my dog, I'm falling down, I'm hitting the trees or whatever. Then I want to ask about the family history. Okay, if there's a family history. So if these 4 questions are yes, okay, you'll need here to consider our case of retinitis pigmentosa. Okay, so the component of retinitis pigmentosa are 4 things: affection of the peripheral vision more than the central. Central will be affected later, but peripheral more. Then night vision problem, color problem, and family history. Okay, here in our algorithm we have a sudden and we have gradual. I want you to remember these circles. Okay, again as usual, you know we like the circles. You need to consider the TIA and the strokes. You need to consider the retinal artery occlusion and the retinal vein occlusions.
you need to ask the 6 questions of clotting. You need to ask about trauma. Okay, I want you to remember for the for the Arabic speaking doctors and other doctors. I know you know Arabic, by the way, because most of you are Muslims. So you need to remember the word تهتم بالسكر والدواء. So you found THTM, تهتم, THTM, تهتم, then diabetes, then drugs. Okay, so تهتم بالسكر والدواء. These are the causes we are using to remember the causes of sudden loss or blurring of vision. Okay, so when we start with the first T, I will say TIA, I will say trauma. And when I say TIA, I mean the TIA or stroke. This depends on if it is temporary or persistent. And when I say TIA also, I would consider the presence of this blood clot in the retinal artery or in the retinal vein. And they can differentiate that mainly by the how the fundus looks like by the fundoscopy. Then to ask about these, I need to ask the 6 questions and add to these 6 questions whether we have any weakness, whether we have any dysarthria, dysphagia. Okay, what are the 6 questions of blood clotting? I'm not going to repeat them. We say that 1 million times. Then the T, we need to ask trauma. Okay, the other T. So TIA stroke, including these, including all the 6 questions with their conditions. Then any trauma to die. So this is for the T. Then I'll go to the H of the TEM. The H has 3 things: hemorrhage, because of the vitreous hemorrhage, retinal hemorrhage, and this stuff. I need to ask about hysterical. There is hysterical loss of vision. Okay, although it is not common, although it will be by exclusion, but you need to ask if the sudden loss of vision happened after stress. Sometime you found the stress. Oh, I can't see. So this would be functional. Then hypoglycemia. This is the third H. Was that associated with hunger pain, associated with excessive sweating, relieved after taking some sugar drinks or food? So these are the 3 H's. What about the T? The temporal arteritis as a cause of sudden loss or blurring of vision. Again, sometimes you'll find my answer. I'm talking about blurring, sometimes about loss of vision. Temporal arteritis can cause, yes, very fast, okay, deterioration of the vision on one eye with pain and tenderness over the temporal artery. This is progenital arteritis, temporal arteritis, and this is very important to diagnose. Will be associated with showing pain, with scalp pain, and it's important because we should give very early steroids in order to protect the eye. Then the M referred to migraine and MS. Migraine is very important, and it came in the exam as a cause of blurring of vision 2 times before recently in the last 2 or 3 years. So you need to ask about any headache. Okay, any headache associated with this blurring or loss of vision. Was it on one side or 2 sides? Any family history of headache? Then the MS, I want to ask about any pins and needles, any weakness. Okay, any feeling of unsteadiness. Okay, so any previous attacks. This is all for the MS. Difficulty in walking. All questions of MS should be asked at screening. Then this is TEM. Then diabetes. I want to ask any history of high blood sugar. So the patient will tell you, yes, I'm diabetic. And this case is very common in the exam, but actually you will tell me the diabetes should do gradual loss of vision or gradual. No, it can cause many things. Diabetes itself can be a risk factor for all of this first piece of the pizza. Okay, the diabetes itself can cause the hyperosmolarity of the lens, and this came in the exam before. Patient coming with blurring of vision only, and he's diabetic and he stopped his medication since long time. And the case was the lens hyperosmolarity because of the high blood sugar. Okay, because the high osmolarity affecting the refraction and affecting the layers of the lens. Okay, so the diabetes still should be considered, and you should ask about even in sudden blurring of vision. And we will ask about it as well. The diabetes and the MS will be asked again in the gradual loss of vision. Then some myths. What are the medications that can cause a sudden blurring of vision? What do you think? Give me some medications that can cause sudden blurring of vision.
Ethanol.
Methanol can cause optic atrophy within 2 days. So it causes it very acutely. Yes, INH. Yes, isoniazide. You mean isoniazide can cause it gradual and can cause it suddenly. Yes, I agree. Insulin, great answer, Dr. Sami Javid. Patient take insulin and go to hypoglycemia, so we'll have a sudden blurring of vision. Alcohol will cause gradual, not acute. So I think we can put the ethanol in the gradual. Maybe the alcohol intoxication can cause it, and alcohol withdrawal can cause it, sudden blurring of vision. Okay. Then don't forget that although not common, will not come to us in the exam, but you need to mention that the eye problem, localized eye problem like infection in the eye and glaucoma can cause sudden blurring of vision, and glaucoma close angle glaucoma is painful as well. Okay. So again, تهتم بالدواء والسكر. So the T for TIA and stroke, including the retinal artery and retinal vein occlusion, the 6 questions and the trauma. Then the H is for hemorrhage, hysterical, and hypoglycemia. Then temporal arteritis, migraine, and MS, diabetes, drugs, and eye glaucoma and infection. This was about the left side, which is the sudden. What about the gradual? Vision or loss. So for sure, you don't need me to say that TIA is including the amyloidosis gas. Okay. So here I will show you these 4. If these 4 are yes, so here I am. You need to consider that. I don't know what's going on. You need to consider the retinitis pigmentosa. Okay. So when these answers are 4 and it is gradual, you will find retinitis pigmentosa will be your answer, and I will show you on the next page how to approach the case of retinitis pigmentosa. That is not far from what Dr. Dr. Samer did. Okay. Once we are talking about gradual loss of vision, you need to ask about headache. Okay, if there is any headache associated with this gradual loss of vision. Whenever the answer of the headache are yes, or the answer is yes, you need to go through this side. I want you to tell me on the chat box how many doctors of you watch my lecture for headache. If anyone watched it, please write in the chat box that you watched the headache lecture. Dr. Adnan, who else? Yes, Dr. Samer, Dr. Samah, Dr. Sami Rohi. Okay, so about 4 or 5 you watched it. Okay, great. Why I'm asking this question? Because this part we use it as the same in our headache algorithm. So study it 1 time. You didn't need to study it 2 times. Okay. When we are asking that, and when we ask about the headache, and the answer for the headache is yes, you need to ask about the signs and the symptoms of increased intracranial pressure. And what are the symptoms of increased intracranial pressure? I want you to ask the word manilbis or bilabis if you want. Bilabis. The M, morning headache. The M for morning headache. The N for nausea. The L. Okay, for leaning forward, the pain increased, the headache increased with the leaning forward. The S refer to sneezing and coughing, so the pain increased with sneezing and coughing. I want you to add to that any neurological weakness or heavy tongue, because the increase in the pressure can cause stroke symptoms. Okay, So these are the questions you need to ask to confirm that the headache here is related to increased intracranial pressure, and it is the cause of the patient's blurring of vision. Okay, and here you will find usually I'm using what is called HPTV. You will find that in the algorithm of the headache. HPTV. If you know the HP as a brand for the computers and TV as a TV, the H here referred to hemorrhage. Okay, so because in the H we use in the headache can be caused by hemorrhage, but actually this will be acute blurring of vision. So you found it in the H here. Okay, but now I'm talking about the headache. The headache can be a cause of the hemorrhage can be a cause of severe headache like intracranial the subarachnoid hemorrhage. So the H, the P referred to primary tumor. Sorry, pseudotumor cerebri, or what we called it, idiopathic intracranial hypertension. And here I want you to correct that, and I corrected that in the other algorithm. This is not called idiopathic when we have a cause. So let me show you in this algorithm. Forget about the headache now because this will be confusing you. The headache I will discuss in the headache algorithm. Here you have a headache. You confirm it by the question of Melabis about if the headache is related to increased intracranial pressure. Then you want to three things: tumors as a cause of this increased intracranial pressure, idiopathic intracranial hypertension. Let's call it increased intracranial hypertension, by the way, benign, or call it pseudotumor cerebri. Then it could be venous sinus thrombosis. Okay. You may ask me if venous sinus thrombosis will cause a gradual loss of vision. Yes, it will cause. It can cause acute, but it can cause gradual as well. The patient have it for a long time and start to cause a severe headache, and then the blurring of vision can happen. Okay. Then I want to ask about this headache. I confirm that it's increased intracranial pressure. So I want to ask maybe there is a brain tumor, and this brain tumor compressing the optic chiasma, for example, or compressing the optic nerve or affecting the occipital lobe. So to ask about primary tumor, okay, what should I ask? Just ask about the normal question for the primary tumor. Bundle 1. Okay. Ask bundle 1. Anyone have a cancer? Will have loss of appetite. Will have weight loss. Will have all this stuff. Okay. We need to ask about other tumors, which is very common for us in the faces, which is the pituitary tumors. So you need to ask specifically about acromegaly and prolactinoma. Very, very common in the exam. So you need to ask about any change in the size of the ring or the shoes. You need to ask about prolactinoma by asking about any, for female, any secretions coming from the nipple. Okay. Any irregular menstruation. For the male, erectile dysfunction. So any problem with the intimate relation, any change of the size of the breast. Okay. Then you need to ask about myths. Whenever I mention tumor, you need to mention about myths. Remember to ask about lumps in the breast, coughing out of blood. These three questions you need to ask when we say tumors. You don't need more details. Any blood coming with the stream, the urine stream. So ask about breast by breast lump, lung by coughing of blood, prostate by blood coming with the stream. So when you ask this question, very simple. Sir, you have blurring of vision since how long? Is it the first time? Is it temporary, gradual, temporary, or persistent? It does happen as sudden or happen as gradual? When he told me gradual, I would ask him about if it's affecting the side of your vision. Do you bump into things while walking? Did you notice it's more at night or in the morning? Do you have a problem with the color vision? Any sudden, any history, family history of the same problem? Then, sir, is it associated with headache? Okay, can you tell me more about this headache? Is it increasing in the morning, increasing with leaning forward, coughing and sneezing, any history of weakness, a heavy tongue? Don't ask, I mean, you don't need to ask every simple word, but at least if you practice that, it will be very simple for you. Once you tell me, yes, I have the headache, I'll confirm this increased intracranial pressure headache. Then I'll start asking about the tumors by asking about, do you have any weight loss and loss of appetite? Okay, any lumps and bumps anywhere in your body? Then I'll ask him about any change of the size of the ring, any change of the size of the shoes. What about your size of the breast? I'm sorry for this question. Do you feel it's increasing in size? Okay, what about your intimate relation? Any problem with that? Then, say, lady, do you have any lumps and bumps in your breast? Do you feel any coughing out of blood? For the males, you'll ask about any blood coming with the urine. So this is for asking about tumors. Then if you are asking about the pseudotumor cerebri, you need to ask about 6 things. 4 things related to weight gain, steroids, oral contraceptive pills, pregnancy. Okay, so weight gain. So weight gain and pregnancy, just to remember, weight gain and pregnancy, this is 2. Steroids increasing the weight, this is 3. Oral contraceptive pills increasing the weight, this is 4. So any patient who gained more weight recently, she is pregnant, steroids, oral contraceptive pills, she may have pseudotumor cerebri, but in the case of steroid, we cause it secondary, not idiopathic, because I have a cause for that. The remaining 2 things for acne, I want you to remember the patient's taking tretinoin, which is rated A, which is a very effective treatment for the acne, but a lot of side effects with that. They discovered that the skin doctors, they found that all the patients most of the patients of their acne, okay, have a problem and they need to go to the neurologist. So when they found that they like to give the tetracycline as antibiotic for soft tissue problems, and at the same time they give tretinoin, both together will cause increased intracranial pressure and all the symptoms that blurring of vision and headache. So you need to know the 6 causes of pseudotumor cerebri or even what's called secondary intracranial hypertension. Then the VST, which is the venous sinus thrombosis, it is a thrombosis, so you need to ask the 6 questions. I want you to add to this fever because of the venous sinus thrombosis, both sinusitis. I will discuss that in the headache algorithm. Okay. So for the headache, we need to confirm increased intracranial pressure and ask this question to check if this is the cause of the gradual loss of vision. Okay. What if there is no headache? And even if there is a headache, and this headache is not associated with increased intracranial pressure, for example. So it could be there is headache associated with this. So I want you to ask about this anyway, okay? If there is no headache, or you want to go through that for the gradual headache, go ahead and ask about the diabetes and hypertension, any long-lasting disease like high blood sugar and hypertension. And this is very common in the exam, just that simple case. As I told you the last day we were together, it can be only case coming with blurring of vision, and you found he is diabetic. You asked about diabetes, and they told you yes, he's diabetic. And the last time he went to the eye doctor was 2 years ago. Or 3 years ago, and now he's coming with blurring of vision. You will look by fundoscopy, you will find a hyperproliferative state, a lot of bleeding. I will show you a fundus for the diabetic patient. A lot of blood or blood hemorrhages. You will find a proliferation of the blood vessels. We'll discuss that. But so you need to ask about diabetes, and very common only to have a patient with diabetes or patient with hypertension coming with edema. Then the MS questions again, because the patient with MS not all the time relapsing in remission. Sometimes the demyelination that happened to the when you have an acute multiple sclerosis will not cause only demyelination. It causes what's called optic neuritis, and this optic neuritis would pain the eye movement because sudden blurring of the vision. So you will find the MS on the left side, on the sudden. But when we talk about the gradual, we talk about the progressive demyelination of the optic tract and optic nerve. Okay, and in this case, you need to ask the MS question. Okay, and it could be the cause. We will look in the fundus and you will find optic atrophy. So optic atrophy is a complication of multiple sclerosis. Don't forget this case may be the station 5, so you will have a finding. Then local eye problems like cataract, glaucoma, aging cause macular degeneration, which is a very common cause. You will find it in UK. They bring a patient only with macular degeneration or macular problem. The patient with macular problem will have a problem in the central vision because the macula is responsible for the central vision. Okay. Then rheumatology disease. Okay, rheumatology. Okay, disease. Because you know most of the rheumatological diseases and even the GI diseases that are associated with eye problems. Okay, so you need to ask about any joint pain, back pain, skin rash. Sometimes it will be just a key for that. Then thyroid eye problem with Graves' disease. You know Graves' disease, when we want to differentiate it from any other cause of hyperthyroidism, you will check the eye symptom. The eye symptoms is unique for Graves' disease. Then what about myasthenia gravis? How to ask about myasthenia gravis? You ask about dropping of the eyelid. You ask about the weakness, as you said in the fatigue, weakness by the end of the day or by the end of any action. Then you need to ask for this patient about job. Don't feel it is a long one because again, you will not go through the left side. You will not go through the details. You may only go here to the circle, depending on the answer. So they need to ask all of these. When you found they are guiding you toward the headache and increased intracranial pressure, go ahead through these and boom, you will get the diagnosis you want. So the job is very important with blind vision. Why? Because the patient's working with leads. The patient working with carbon monoxide. The artist, the carbon monoxide, the artist, the mechanics, the battery workers, the construction workers, they are all exposed to lead and carbon monoxide. Okay. Then drugs, which is medication. Steroids can do gradual loss of vision for sure and cataract. Ethanbutol can cause gradual loss of vision, sometimes acute as well. Hydroxychloroquine can cause gradual loss of vision and acute. So ethanbutol, don't forget. Okay. And the hydroxychloroquine. Okay. So these are the known causes of the gradual loss of vision. So this algorithm, I want you in your studying to note by heart after we finish the course. Not now, not these days. A lot of algorithms you are receiving, so it's not easy to digest that all. But believe me, with time, you'll just memorize this page. Inshallah, you'll pass the test as all your colleagues did. They just, alhamdulillah, they all appreciating remembering this page, which makes studying the things more simple. Okay. Examination steps for this patient. Dr. Sami Javid asking me for this patient.
In this case, doctor, I just want to add that sometimes you just need to go through the chronic causes, even if there is no headache or there is headache. So all the differentials in the chronic. Okay, I would say that both of the circles, if you are in history station and you have time, go through all these differentials. Okay, but depending if it's coming like chronic, okay, start with this group and ask about the headache, because sometimes there is headache and there is also any of these. So I mean, having a headache, okay, will not mean only you need to go there. Yes, you need to go and exclude these, but you still any of these causes, the hypertension, diabetes, or any of these steroids or whatever, it can be associated with headache. So the principle of no headache, I don't agree with this exactly, but I mean, if there is headache, you need to go there. Okay, but this will be plus or minus headache. So if there is headache or no headache, you need to come to this circle. I hope this is clear. I mean, there's nothing that say hypertension can be with headache, diabetes can be with headache, so no glaucoma can be with headache. So remember, no headache doesn't mean that if there's no headache, there's no of these. Just remove this no and make it minus and plus headache. So any of these can be with or without headache. Okay, I hope this.
Okay, we need to go and examine first of all for the patient with pigmentosa. You will examine the eye first. Okay, when you examine the eye. Okay, when you examine the eyes, you need to examine the visual first acuity. If you found there is loss of vision, don't offer to examine the field because the patient can see your fingers as well. Okay, so you examine the eyes. Okay, and you need to go ahead and examine the eye movement. You should examine the eye movement. You need to examine 2 and 3 and 3. I mean, 3 and 2 and 3 and 4 and 6. Okay, you need to offer examining hearing. You need to offer examining ataxia, the patient walking. You need the patient to walk in front of you. You need to offer examining the hearing. This is because the syndrome associated with retinitis pigmentosa. Okay. Here for the retinitis pigmentosa, what I'm going to say now is not super important because you are not expected to catch the definite diagnosis for the retinitis pigmentosa, but I want you to know as much as you can. This will impress the examiner, and if he's silly and want you to catch this, go ahead. Again, I'm not expecting you to know this by heart now, just try to understand what I will say. The 4 components of retinitis pigmentosa are family history, tunnel vision, color vision, and night vision, and we went through that, and now you know how to ask these questions. Then you will ask him about any problem in hearing. If no problem with hearing, you will think about the Bradet Biddle because the Bradet Biddle have another criteria, but not affecting the hearing. Okay, so what will the Bradet Biddle include? Okay, the Bradet Biddle will include, we call him Badin and Balid. Badin means he's overweight. Balid, he has a learning difficulties. Okay, but these patients as well, they have polydactyly, which is a multiple fingers. So there is a finger, extra fingers. Okay, they may have also kidney problems. Please write this down because it's not written. So you need to ask. This is merging with what's called Lawrence-Moon, but actually they divide to 2 syndromes. So for us, the Bradet Biddle, okay, will be associated with, we said Badin and Balid, so patient overweight and with learning difficulties, they have some mental and intellectual problems. There could be an extra fingers. And you need to ask about the amount of furin, the color of furin, and this stuff. Okay, this is when there is no deafness. I will ask first about that. Ask about any extra fingers. Okay, any learning difficulties. Then, if there is this deafness, I will ask the next question: any unsteadiness? Because now we have retinitis pigmentosa and we have deafness. So, when to ask if there is unsteadiness. If we didn't find unsteadiness, so we only have retinitis pigmentosa and we have deafness, but nothing else. So here I would think about what's called Usher syndrome. Usher syndrome is hearing problem with vision problem with retinitis pigmentosa. Some of you will tell me Alport syndrome. Alport syndrome actually is not associated with retinitis pigmentosa. It is associated with things affecting the iris and the lens more than the retina. Although you found some books including that, but I searched that Alport is not associated with retinitis. It is associated with other eye problems. So whenever I have deafness, vision problem, okay, and I will go to ask kidney problems about Usher's, okay, and hearing problem. Then I will go to if there is unsteadiness. So now I have unsteadiness and I have deafness and I have vision problem. Okay, if there is only this, okay, but associated with diarrhea. I mean, you found unsteadiness. Okay, there is a lot of things will appear now. There's unsteadiness, deafness, and diarrhea or lost motion. So this will be a beta lipoproteinemia. This patient will have tummy pain. They will have ataxia because these people have spinocerebellar degeneration. It is affecting also the dorsal column, and we will discuss that in the neurology lectures. Okay. So for beta lipoproteinemia, there will be steatorrhea, lost motion, tummy pain, ataxia. Okay. So whenever again, this is very tough. Just remember what you can remember of that. When you ask this question, I would do that in the basis exam. I will ask, sir, I found it's relative pigmentosa. I did very well. I'm near the full mark. Any deafness problem, any unsteadiness, any lost motion, I will ask it that way. Any pins on needles, so I just ask these 4 questions. Any weakness, I will ask these 4 questions and I will go through that. I'm just making that to make it more easy for you to remember whatever what you can remember. They are not expecting you to catch this diagnosis. They will be satisfied by retinitis pigmentosa. But they need to ask this question to show that you know the syndromes. If there is a diarrhea, we said abetalipoproteinemia. No diarrhea, I will ask about pins and needles. Again, no pins and needles, no diarrhea. So it is unsteadiness and deafness only with the eye problem. Or think about what's called Kearns-Sayre, which is associated with heart block. So I need to ask about heart block with Kearns-Sayre. Then if there is pins and needles, I would consider, not Friedreich ataxia actually, Friedreich-like ataxia. If there's weakness, no weakness, but there is pins and needles, I consider Refsum disease. Refsum disease. So Refsum disease related to what's called phytanic acid, when the patient has a problem with phytanic acid. And it is associated with ichthyosis, and you will show the ichthyosis in the dermatology day. So the component of retinitis, Refsum disease, there will be peripheral neuropathy, there will be eye problem with retinitis pigmentosa, there will be ichthyosis, there will be maybe ataxia. He's unlucky patient, by the way. Okay, and this is how does it look. It's like bone spicula around the blood vessels. There's retinal pigmentation, you found it around the glass, and here is the pale disc. So there is a pale disc of the retinitis pigmentosa optic atrophy.
Okay, doctors. So it's the time for break. So first of all, I want to know, did you get the point of the blurring vision? Is it okay with you now? Blurring vision and retinitis pigmentosa. Give me the okay in the chat box, please. That you're okay with this algorithm? You can add some stuff on that, will be included. So eventually we'll be adding some stuff. Okay, when you take the Herrick algorithm. Okay. It's okay. So some of our doctors, they went to pray Friday and they will join us. So I'm just reminding, if anyone wants to go to pray and come back and join us, then continue. Okay. Yes, Dr. Norman, go ahead. I mean, I have a different time zone. It's 2 a.m. in my time. So go to pray and come and continue. So at least when you wanted that, there's 2 hours remaining on the lecture or something, so it will be easy to watch it. But if you just say this is Friday and I'm not going to attend, I will see the record, then you would never see the 6 hours. Okay. Okay. So we're going to pray now for, we will give 20 minutes. Is okay for break? 20 or 15? Tell me, please. 15 minutes. 15 minutes break is okay. Make the voting, please. Dr. Afra said 15, Dr. Mina said 20. What about the others? Dr. Shazia said 15. 15. So yeah, Dr. David 15. So all of you went with 15. Okay. So let's meet 12:35. 12:35. Thank you. Okay, hello, doctor. Are you there?
That's it. In this case, that sample, it came the same in Oman, in the pre-last diet. So, okay, so I opened your mic now. Hello?
Yes, doctor.
Dr. how are you? Try to raise.
Fine, doctor.
Yeah, great, I can hear you.
Okay.
So this is station 5 case. Simple one, inshallah. Try to follow that person, please. I trust you will do it. Can you start or do you need some time?
Just 1 minute, doctor. Okay, doctor, we will start.
Okay, sure.
Hello, Mr. Adnan. I am Dr. Sadaf. I'm the doctor in the clinic today. Are you, can I confirm that you're 51 years of age?
Yes, I am.
Okay. How are you, Mr. Adnan?
I'm good.
Okay. Mr. Adnan, it has been brought to my notice that you have some problems with your vision and weight. Is that right?
Yes.
Can you tell me more about it?
Yes, doctor. Since 2 years, I start to find that my vision start to be, or my sight start to be not the same as before, and I start to have some troubles in my vision. And I also noticed that I'm gaining more weight.
All right. And your vision, let's go one by one for each of your problems. Your vision, it was sudden or it was gradual?
No, actually, it was gradual, doctor. It takes some time and it's getting worse.
All right. And do you have any weight gain, you said? How many kgs of weight did you gain?
Not 7.
7. And it was intentional, unintentional?
No, not intentional.
Okay. And regarding your vision, is it associated with any headaches?
Headaches, yes, doctor. I'm suffering with headaches all the time.
All right. And do you have any loss of vision in one eye or both eyes?
I have, it's not actual loss of vision. It's a blurring and problem in my vision. It is in both eyes.
Okay. And do you notice that you are bumping into objects when you're walking?
Yes, doctor. I noticed that.
Okay. And the sides of your vision are affected or the central vision is affected?
I think the sides both are affected. Okay, and my vision is not as before, but my side vision is more affected actually.
Okay. And do you have any problems in driving?
In driving, yes, sure, because I can't see the sides. I break the mirror of my car many times.
Okay. Okay. I will advise you first of all that till we come to a diagnosis, please do not drive and do inform the DVLA till the time. All right, till we treat your condition. Okay. Can I ask you that do you have any increase in the shape of your face or anything like that?
Yes, doctor.
Okay.
Increase in the shape, you mean change in my face features?
Yeah, exactly.
Yes, doctor.
And you feel that your ring size has increased?
My what?
Ring size?
Yes.
And your shoe size?
Yes, doctor.
Okay, I'm so sorry to hear that. Do you have any problems with your, do you have any pain in your arms?
In my arms, little bit.
Okay. Do you have any problems with high blood sugar or
Yes,
high blood pressure?
I was diagnosed with diabetes 2 years ago, 1.5 years ago. Okay. And
what medication?
Yeah, recently it's never controlled. Yeah.
Okay. And any other disease, any other problem you have, medical condition, like high blood pressure?
I have high blood pressure also.
Anything else you have along with that?
No, doctor. Nothing.
Okay.
No.
Okay. I'm very sorry to hear that. I will also ask you, are you taking your medications regularly for your diabetes?
Yes, doctor. I'm taking my medicine, but it is never controlled.
Okay. I will try my best to bring it back to a proper normal level. What about your blood pressure? Are you taking any medications for that?
Yes, I'm taking Ramipril.
Okay. And is it controlled?
No.
Okay. Are you taking your medications regularly?
Yes, doctor.
Both of them. Okay. What was your last blood pressure?
It was, I'm not sure, doctor, about the number.
It was high. All
They
right.
told me it is not controlled. And I'm
All right.
the one who's going to my doctor regularly. I'm very busy, doctor.
Okay. I'm so sorry. Okay. Can I ask you that do you have any problem when you wake up from sleep gasping for air?
Yes, doctor. I'm waking. My wife told me I wake at night many times gasping for air.
Okay. Now I would ask you one more thing. That do you have any shortness of breath, racing, pacing of your heart?
Yes, sometimes, doctor.
All right. Do you have any history of alcohol? Do you take alcohol?
No, doctor.
And do you smoke?
No, doctor.
What is your job?
I'm a farmer.
Okay. And is this affecting you in any way?
Yes, sure, doctor.
Okay. I will refer you to an occupational therapist who will deal with that issue of yours. I hope that will be helpful for you. And regarding your medications, you told me, any other medication over the counter are you taking without any doctor's prescription on your own?
No, doctor. No.
Okay. And regarding your, are you married?
Yes, doctor.
You have children?
No, doctor.
And you have any problems with your personal life and with your wife and such?
Yes, recently, doctor, I have problem with my intimate relation.
Okay, I'm so sorry to hear about that. Okay, and do you notice that? Okay, I would like to examine you. Is that okay with you?
Yes, sure, doctor.
Okay, I would like to first of all see the shape of his face. Okay, and his hands
Yeah, it's
Teeth.
big hands.
Okay, teeth. If you have a teeth, and all right, and the feet and the hand, the shape of the feet hand. Okay, I'll look at the fundus now. First of all, look at the visual acuity. Okay, this is the, oh my god. Okay, this is okay, and I will also see the visual field. Visual field also examine. Pardon?
Acuity.
Visual acuity and visual field. Yes.
2 minutes remaining.
Okay. What are your concerns, Mr.
I want to know, Doctor, why this blurring of vision and why I'm hitting the things while I'm walking.
Okay.
That's related to my diabetes.
Mr. Adnan, no, it is not related to diabetes, but diabetes is related to the condition you are having. You're having a condition called as medical condition called as acromegaly. Don't bother about the name. It is a condition in which you have a gland in your small gland in your brain, endocrine gland, which secretes some hormones which are uncontrolled, which are too much, and these are causing the different problems with your high blood sugar, high blood pressure, and the increased shape of your face and your hands and your legs and your feet. And also, this has caused, because of the high blood pressure and high blood sugar, you have problems with your vision. Also, your condition is causing the problem in your vision. So we need to do some imaging for you, a brain imaging, and we will do some involve a multidisciplinary team involving the eye doctor, sugar doctor, and blood pressure doctor, and the gland doctor, and also yeah, all of these doctors together. We will make sure that we treat your condition if it requires giving some medications.
Okay, thank you. Okay, questions, doctor. What's your differential diagnosis for this patient blurring of vision?
My differential diagnosis for this patient's blurring of vision is acromegaly complicated by hypertensive retinopathy, and also bitemporal myopia complication of acromegaly, and also diabetic retinopathy.
Yeah. Yes. What was your finding in your in the fundoscopies?
On fundoscopy, I found multiple plane-shaped hemorrhages. Cotton wool spots.
Okay. What else?
Neovascularization.
Neovascularization.
AV nipping.
AV nipping. What is the AV nipping? At which time?
5 o'clock.
5 o'clock. Okay. Do you see any hard exudate?
Yes, I do see.
What about the disc?
There's an optic atrophy. I'm so sorry about that. I'm not sure about that.
Okay, what are you going to do for this patient?
I'm going to do MRI pituitary. I'm going to run, first of all, basic test for his blood pressure, blood sugar, and also the renal function and liver function. But most importantly, I'll do the MRI pituitary, and ultrasound abdomen, CT abdomen, and treat the condition. If it is requiring somatostatin analog, we will give that. Or if it requires pituitary tumor resection, we will do a transphenoidal pituitary adenomectomy.
Okay.
Adenomectomy, yes.
Would you go to the space?
Pardon?
You go to the space by yourself? It looks like you'll do everything yourself.
I will involve a multidisciplinary team, and the team will constitute of a endocrine surgeon, diabetologist, ophthalmologist.
Is there any need for urgent referral to the eye doctor?
Definitely. Yes, I will make an urgent referral.
Thank you, Dr.
Thank you.
Okay, it's the time for the examiners. Go ahead, guys. Scores. Wow, I forgot to close the chat so you can see your marks. What do you think? Now I close it. Now you can chat with me only. Okay. Okay. Your colleagues likes you, Dr. Sadr. Yeah. So yeah, about 90% of the candidates give you 28. I agree with them, but I have some comments. Okay. I agree with them because again, the examiner will understand the challenges in the cases. Okay. The challenge of the time, because this is, yes, I like when you give the differential. The trick in this case that you will give the differential. The patient has two problems in his vision. The first one related to the vision field, okay, which is explained by possible compression of the optic chiasma, okay, and he has another problem with the vision itself because of the retinopathy he has due to the uncontrolled diabetes since 2 years without follow-up of ophthalmologist. You should ask him if he is visiting the eye doctor or not. This question should be asked, right? Okay. The other thing, you need to highlight the patient problem. I mean, the patient didn't come mainly for the acromegaly. I agree that you need to say the diagnosis of acromegaly, but you need to examine the eye first, and you need to pay more attention for examining the eye, starting by the eyes. So you need to examine the visual acuity. If it's okay, examine the visual field, right?
Right.
Okay, then after examining the visual field, you'll go to examine the fundus. You started the examination very late. In this case, you should, it is acromegaly after how, what do you think? When this patient's in front of you, do you need more than 1 minute to know that he's acromegaly?
No.
So you spend more time in the first hexagon in confirming. So confirm it. You don't need to ask about every one single thing. Now it is confirmed. Okay, and remember why the patient is here. Okay, so you confirm it by asking some questions about the ring, about the shoes, and this. So this is an acromegaly. The patient coming with blurring of vision. So you ask it about the diabetes and hypertension, and you ask the smart questions about the control and the compliance. And this impressed me very much. Okay, and you ask this very fast and utilize the time perfectly, except for delaying the examination. If you ask it all these questions, if you told me that I'm going to examine you and I will keep asking you during the examination from the second minute, okay, you'll take clear 28 marks. Okay, the other thing. So the first comment I wrote there was about starting by the eye examination. You usually start by the complaint of the patient. With the patient coming with problem in the eye, look to his eye first. Start with examining the eye, then go and offer examining. I would like to examine his chest for his heart. Okay, I would like to examine the back. Okay, I would like to examine his knees for certain. I would like to examine the abdomen for the organomegaly. Okay, you need to offer that, and the examiner can tell you it's your time, or he can tell you no need. Okay, so all this this will be his response. And the trick in this case also, if you have time, and this is important, as I said, this is a diabetic patient. Actually, in station 5, you will not have time to ask everything. But if you didn't mention to the patient that he should be seen by the heart doctor, by the eye doctor, by the you need to go to foot care. You need to be seen by if there's pins and needles for the nerve doctor. So try to say that very fast, but while examining him, you start very late and you spend a lot of time in confirming the diagnosis, which is already obvious, you know? Okay. I mean, if this patient, he didn't mention that he has problem in his intimate relation and he's coming for blurring of vision and it is station 5. So no need to go to this point because there is more important point to comment about, right? Okay. So it's about time utilization. Actually, you'll get, if you read my opinion, this is a 28. You'll get 28 in this case. You catch what they want in the diagnosis. You see, there is one problem. I will suppose that you will never do in the exam, okay? Because actually you will not get 28 if you did that. Never mention something not obvious to you in the examination, okay? There is no AV nipping. Okay, at 5 there is no AV nerving here. I can't see any AV nerving, and they will show you how the AV nerving looks like. Okay.
Okay.
The other thing, the exudate, the hard exudate is obvious, and there is no optic disc atrophy. Okay, this is not optic atrophy.
Yes.
Okay, so if you are not sure, don't comment on that. It's enough to say there is multiple blood hemorrhage. There is, you said cotton wheel, you said there is hard exudate. It's enough. But when you start, if you tell them there is a disc atrophy, they'll tell you, really, take a look again. Okay, and they want you all to be smart again. If they said, okay, there is he told you, look again, examine the arm again, examine something again, please go and examine and change your word. Don't act smart and say, oh, they are tricking me. They are not tricking you. They are trying to help you. Sometime while the examiner is asking you, he will tell you, really, there is optic atrophy. Can you look again? Okay, so go and look again and tell him, oh, sorry, it is not optic atrophy, because in this case, they are not tricking you. They're just trying to help you. Because some of the candidate, they don't go, they say, yes, there is atrophy. The examiner will not tell you to look again, and he will waste his time. He just give you the chance to give you the full mark. So if he told you look again, go and look and just confirm what. If you are sure 100%, just tell them. He may take a look again. But this happened with many candidates. They say optic atrophy. The examiner tell him take a look again. He take a look. It's optic atrophy. Then one of the examiner take the ophthalmoscope and he take a look. He take a look. There is no optic atrophy. So they say okay. So then they will write inventing symptoms, inventing signs. Okay. So if you are not sure, as I told you, remember, never assume that there is something there. Just use 3 or 4 things which are present. So it's enough, right?
Yeah.
You agree with me?
Yes,
Perfect,
yes.
perfect performance, very fast, very professional. I like it very much. Thank you, Dr. Sadaf. Excellent.
Doctor,
yes.
Yes, thank you. Sorry for cutting you. Doctor, please, I need one real help from you. When I have tried to see the fundus of as many patients I can in my clinic, but doctor, I am failing to reach on my own. I do the setting plus 10. How much number should I put in the fundoscope?
It depends on your vision. You mean which number you put in fundoscopy?
Yeah, in the fundus. I am having corrected vision, and my vision is 6/6 if I'm corrected with contact lenses. But when I put the fundus in the eye of the patient, I was able to see only the optic disc, because by the time I reached, the patient was extremely tired. It was plus 10. I reached the retina of the patient, and I could only see a normal optic disc. I want to ask, what is the technique after plus 10? What should I do further to see more better?
It looks like you don't understand why the number for Dr. Sadaf. The number is for the correction. The number is for the correction of your vision with the accuracy of the vision. So once, whatever the number you will put, there is no number you will adjust for everything you want to see. I mean, once you have the clear vision of the blood vessel, for example, usually we are not adjusting on the disc. I mean, once you look and you start to see a clear vessel, this is the number is suitable for your eye. Okay, then move from the thin part of the vessel inward. I mean, let's say that you look. This is what you see. This part, okay, and this is the blood vessel, or this part. You will move with the blood vessel, okay, toward the blood vessel become more dark, become more big, and go to the disc. I'll show you another slide. Will be more obvious for you. Okay, so you keep moving by the vessel direction toward the disc, but don't. I think you misunderstand this point. You think that we need to adjust the number based on what we are going to see, and this is not correct. You just adjust it in some spot once you see the vessel clear. So this is what is suitable for your vision and for the picture now. Just move slowly and go. The problem that your hand may be moving, so you keep looking in a different areas, or your fundoscopy is moving in your hand, but it would never be. You need to adjust for plus 10 here, then plus 5 here, because your eye is still the same eye and his eye is still the same.
Okay.
This is sure. There is nothing in the fundoscopy based on you change the number to see a certain thing. Okay, it's for the blurring of the lens, not for amplification of the picture. Okay.
Okay.
Okay. So Dr. Ahmed asking a question. Dr. Ahmed asking what about optic edema? It is not optic edema, Dr. Ahmed. Actually, I still see the edges here. If you can draw it, don't mention the optic edema. I mean, if you can catch your pencil and draw the disc, don't mention the optic edema. We need to comment on the optic edema when you can see some. Let's say you see this area, which is you can see the edges of the disc. And when you see this case, you can see this optic edema. Otherwise, if you still can see these edges, you can draw it by a pen or pencil. Okay, so you are not confident to say optic edema. Dr. Shema asking Dr. Ahmed to find the diagnosis finding of this case. The finding, I will show you now. I will discuss it now, Dr. Shema, all the detail. And if you recommend fundoscopy model to buy, I will tell you as well. Or what should I look for by one? No, there is one. There's a specific type only you can bring. The others are garbage. Okay, but okay. We will discuss that. So now let's. Dr. Sadaf, you did very well. Perfect.
Thank you so much.
One second, because I will turn off.
Okay, doctors, this is Dr. Sharif, your question. Dr. Sharif asking, are we going to do fundus examination by ourselves, or they will give us a photo if we open? No, for sure you will do it, Dr. Sharif. The fundoscopy is a nightmare for the new candidate for cases, and it's a false nightmare, because eventually this will be one of the best cases you may see in the exam. When you learn how to do the fundus examination, it will be very simple, because it's something there's not many options that you can see in the fundus of the patient. So it's whether optic atrophy, optic edema, diabetic eye change, hypertensive eye change, retinal artery stenosis, retinal artery occlusion, retinal vein occlusion, and retinitis pigmentosa. So it's only 5 or 6 cases that you can see in the fundus. So this is a great option compared to any other case of station 5 that would be with up in possibility of thousands of possibilities. So don't worry about that. You need to learn what I'm teaching now in this part, because when you go again to your clinical course, you need to know what you're going to look at, what you're going to search for. So you not spend the time only trying to see the anatomy. You will learn that, don't worry. Again, you will not see it. You are worried about that because you didn't try before. The internal medicine doctors are not used to do that, but actually you will learn that and you'll be more than perfect in that. But you need to go out of the course and you know exactly what the abnormality is you are going to look for. How to look for that, this is what you will learn in your clinical courses with practicing the cases, okay? So now we will go to the discussion, and this will give you some confidence.
Sorry, I was preparing some bit on the fire. So let's go here. First of all, I want to tell you about the differential diagnosis of the optic atrophy or the cause of optic atrophy. As you all know, that the mnemonic everyone uses for that is pale disc. Based on the name of the optic atrophy, there is a pale disc, so you will follow pale disc. These are the causes of the optic atrophy. So for the P, okay, so increase the intracranial pressure, okay, and increase the intraorbital pressure. So glaucoma can cause optic atrophy, and increased intracranial pressure can cause papilledema and then optic atrophy. So papilledemic optic atrophy is a very common to see some disc pale from a side and papilledema on the other side. One eye with papilledema and the other eye with optic atrophy. So increase the intracranial pressure and increase the intraorbital pressure, both can cause optic atrophy. The A4 ataxia, Friedreich ataxia is associated with optic atrophy. Okay, this is one of the genetic hereditary disease called Leber's optic atrophy. Nothing specific for that in the exam at least. For the D referred to degenerative, here remember the retinitis pigmentosa and vitamin B12 deficiency with dietary. Okay, then the I referred to ischemic, patient with Jensen arteritis and Wigner and Charge-Strauss, they have vasculitis, and this vasculitis will cause ischemia to the disc. Then the S, and this is the most important, the most common in the exam, okay, is the multiple sclerosis. Then the C referred to cyanide, okay, cyanide poisoning, ethambutol, methanol, ethyl glycol, and as I'm always saying, there is one patient, it was the first time for me to see a patient where he drank methanol, which is the red alcohol, okay, and he said in the same day he became blind. When you see his eyes, his retina, there is the most pale disc I see in my life. Okay, so just try to memorize this one, pale disc. Okay, for the causes of the optic atrophy. Okay, multiple sclerosis is one of the most common causes. Papilledema is common to be seen there. I will show you first what is the normal fundus looks like. For the doctor who never seen fundoscopy before, okay, first of all, don't worry, you will be used to do that. The technique, you will learn that in the clinical course. Usually you look, you don't see all this picture, you only see this spot, because some of you never see that, so you don't know. So you'll see this will be the spot in front of you. Okay, so you want to know how to reach the disc. Your aim, your target is to reach the disc. Okay, so once you look here, you will start to follow the vessels nasally. So once you are here, okay, the vessels very thin and tiny, so you will keep moving nasally with the vessels. The vessels become more obvious, become more crowded. You see here, become more crowded. Then you will reach the disc. So in some field, you will see this box, okay, or half of the disc or one. Once you are in the middle and this is the vessels, this is the disc. Once you see the disc, you need to look for the surrounding, the edges of the disc. You go around the disc. Here the disc looks good, the color is okay, and draw a line around it. So it looks okay, and they can draw a line. And draw a line, this is for papilledema. But in optic atrophy, you will see it is very finely drawn. So when you see optic atrophy, you'll see pale disc, and pale doesn't mean it's not obvious. It's the opposite. When it is pale, it's more easy to see. It's very obvious. It is not shiny. I mean, it's pale. It looks like a white or pink spot on and dark orange floor. Okay, and you will find the edges very dark or very sharp. Okay, so here this looks orange. Actually, I can say it is white or pink. It looks bright. Okay, and the edges is okay. So this is the optic disc. Okay, this is the vein, the thick part in the fundus. This is called the vein, and the arteries are more thin. So the arteries are the thin, and the veins are thick. And this area, usually you tell the patient to look forward. Okay, the patient is looking forward, and you are looking here. Okay, and to see the macula, and in the middle this dark area, which is called the fovea, you tell the patient to look straight to the light. So the patient in the beginning, you are looking from the side, and he's looking forward, not to the light. So you go to the disc. But when you want to look to the macula, the center of the retina, you tell the patient look to the light. But you need to dim the light, because if you didn't dim the light will be reflected on the macula, and you will say this is a hard exudate. Okay, so usually you just dim the light. This is the last thing you do. You dim the light, and you tell the patient to look to the light. Usually you will learn all this technique in your clinical course. You need to practice and see many cases, but at least you need to know the basics. So when you look, you know what you are looking for. Okay, let me go ahead and show you. Okay, what's going on in the diabetic retinopathy. Okay, this is called hard exudate. This is called hard exudate. You see this? This is the macula, as you said, in the middle. This is the macula, and this is the fovea. Okay, and here the macula and the fovea is filled by the hard exudate. What is the hard exudate? It is extravasation of lipids. This happened with diabetes. So it is extravasation of the lipids, giving this hard exudate. It looks like the shiny dots of gold. It's like there is a gold powder, and you throw there on the retina. Okay, when it's affecting the periphery, it is just hard exudate. When it's affecting the macula, so it is an emergency, because this is called maculopathy. And maculopathy is indication for urgent referral to the ophthalmologist. Okay, because once the macula, if there is any big trouble in the macula, the patient will lose his vision. Okay, so this is called maculopathy. Okay, and there is what's called blood hemorrhage. Okay, so this is blood hemorrhage. Okay, so you mentioned this blood of hemorrhage. These are the veins. Okay, sometimes you will see what's called macroaneurysm. Okay, you can see microaneurysm. There will be some circles in the vessels like aneurysm. If you didn't see, don't mention it here. You need to mention the hard exudate. Okay, and you need to, and this is urgent referral because of this macula. Okay, in advanced stage, there's what's called cotton wool spot. Okay, the cotton wool spots. This is area of ischemia. You know, it looks more pale, not shiny like the hard exudate, because there is ischemia. The arteries here can't send enough blood to the retina, so it looks like a cotton wool. Okay, and this is area of ischemia. So this is extravasation of the lipid, and this area of ischemia, so it looks more pale and it looks like a cotton. Okay, and you can see what's called flame hemorrhage. It's like a flame. It's like a fire flame. Okay, so there is a blood hemorrhage and there is flame hemorrhage. Okay, so this is an advanced stage. Okay, then the worst stage is the proliferative retinopathy, when there is a new vascularization because of the ischemia that's happening. You see this here at 5 o'clock. This is again ischemia. This is soft exudate. This is called the cotton wool spot. And here, this is the new vascularization, and this can destroy the retina. There could be bleeding at any time. It can also destroy the optic disc as well. Okay, so this is a super emergency, and this should be urgently referred to the ophthalmologist, and they will do laser therapy immediately to the eye for that. This will be the treatment for that. Okay, they need to do photocoagulation. Okay, so I'll show you on the next slide, and you understand every word here. This is after the photocoagulation. You see they start to burn the things. Please don't mix between. When you see this image, it is not classic. Sometimes all these circles looks white only. This was a recent one, but after a while it will be only white. This is the site where they do the coagulation. When they do this coagulation, they start to just burn these blood vessels, these extra blood vessels, so hemorrhage will not happen, and coverage and destruction of the retina and this will not happen. So this is because it's recent, but sometimes it will be only white. Some candidates, when they see that, they say it's bony spicula and this is retinitis pigmentosa, and it is not. It will be in the periphery like the retinitis pigmentosa, but in the retinitis pigmentosa it looks bony spicula. This is not what it's like a circle. Circles, some of them are dirty, and sometimes you'll see it's all white. Okay, here is a picture, it's a known picture for the proliferative diabetic retinopathy. You see the proliferated, the extra growth of the abnormal blood vessels. You see this is hemorrhages. This is hard exudate. Okay, this is the microaneurysm there, the blood vessels. Okay, so this would be the change. You can see you need to practice as much as you can. For this is the evening yourself. You see, when there is a crossing, AV nipping or AV nicking, we can call it both. Okay, you will see when the artery going across the vein, it will be like it cut the vein. You see the vein is cut here. The vein is cut. It looks like it's nipping. It's pressing it. You see, it looks like the artery cuts the vein. Are you with me, Dr. Sadaf? Is it? If you open your mic, I want to be sure that you know now what's meant by it. Dr. Sadaf.
Yes, doctor, I can see.
You see, this is the, you see now it looks like it's cutting the vessel, and this is obvious. This wire, you see this vessel when there is a wire, it looks like a wire inside the vein. This is inside the artery. We call it the silver wiring. You know, in all the patients you'll see the silver wiring. Okay, silver wiring is a sign of atherosclerosis. Okay, so because this is very tiny, small, thin vessels, it looks silver wiring. It's like it's a wire with a silver inside. Okay,
yes.
This is the disc that can you draw a line around this disc?
No,
you can't. This is papilledema.
right.
Okay, this is papilledema. So papilledema, AV nipping, this soft exudate with multiple ischemia, these are all signs of hypertensive retinopathy. So in hypertensive retinopathy, I would expect to have in the fourth stage or in the stage 4 papilledema. Before that, we can find hemorrhage and exudate, the AV nipping. So if you need the stages, although you will not be required to mention it in the exam by stages, but stage 1, there's attenuation of the vessels and silver wiring. You see attenuation of the vessel and silver wiring. In the stage 2, there will be the AV nipping. Okay, then in stage 3, there will start some hemorrhage and cotton wool spots. Then in stage 4 will be papilledema. Okay. Okay, doctor. Soft exudate is the cotton wool, which is ischemic, which is the ischemic change. Okay, there is the flame shape wires. Okay, the flame shape wires are pathognomonic for hypertension. The flame shape wire bleeding is pathognomonic. It is very common, and it is one of the common things to see in the hypertensive retinopathy. Okay, usually the diabetic patient is hypertensive, so you may see mix of both. So just mention what you see. Okay, the hemorrhage just came in. That's exactly. It's not difficult. Just these. That's all what you want to know about them. You don't need to be ophthalmologist. You just want to show him that. Okay, I want to see you a picture for. This is the optic atrophy. Take a look. What do you think, Dr. Sadaf, about this one?
Oh, it's a very clear. Yeah, we can draw around the.
It is already drawn. Not you can draw. You can draw around the normal disc as well. I mean, if you can't draw it, this is papilledema. Okay, if the edge is blurred. But if you can just see it, you can draw it, and it looks the color is nearly the same as around. So this is a normal disc. But you see this disc, it looks like somebody draws apart by a pencil, and it looks pale. Pale is not. This shine is due to the light itself, but it will look very obvious. And this is not the color of the disc. The disc is orange. Okay.
Okay.
So it looks like, you see, it looks like somebody draw it, and it looks bright, not shiny, but it's bright. The color is sometimes it's white, sometimes it's little yellow. Okay, but the normal disc looks orange. Okay.
Okay.
So you need to see multiple variation. Before you click a code, just go to Google and write optic atrophy and see 100 picture. Then write optic edema. Okay, papilledema, and see 100 pictures. So when you see the real patient, you rate reserve of the pictures you see before. Okay, for the fundus. For these two pictures, I want to show you. This one is this was a retinal artery occlusion. Okay, you see retinal artery occlusion. This all becomes ischemic. All the retina becomes ischemic because of retinal artery occlusion. If it's a branch, it will be area of ischemia, and this is causes ischemia. All the retinal ischemia. It's like somebody throw some Clorox on the retina. Okay, in this picture, this is a retinal vein occlusion. When there is a retinal vein occlusion, it will look like a bleeding. It looks like
tomato pizza.
What?
Tomato pizza.
I can't hear you.
Tomato pizza.
Yeah, tomato pizza. Okay, it looks like tomato pizza. Okay, so this is how it looks like in the fundus. Again, just write every one of these diagnoses, and I'll collect some pictures for you also when I can't do that. Okay. In this case, Dr. Sadaf, as I said, diabetes. Do you remember the diabetic NPH? If you have time, you need to go through diabetic NPH. We discussed that the last lecture. In the case of Charcot joint, the D is duration, since how long you have diabetes. The I for insulin and other medication, and if the patient is compliant or not. The A referred to A1C, what was your last A1C. The B for blood vision, and the E for eye exam yearly if you're attending. The T for traumatic food ulcers and Charcot joint and attending food care. The C referred to cardiac risk factors like any hypertension, hyperlipidemia, and previous stroke. The N for nephropathy, any frothy urine in the blood coming with urine, amount of urine. The P for peripheral neuropathy, any pins and needles. The H for previous attack of hypoglycemia. I want every one of you to know that by heart and to practice how to ask these questions in not more than 1.5 minutes or 2 minutes maximum, because I'm sure at least 20% of you will have a case of diabetes in the exam, whatever how it will be. Okay, so now because this case was discussing the blind vision on the side with the bitemporal hemianopia. Okay, there will be many cases appearing recently with the hemianopsia with different visual field problems. Okay, so you need to have an idea about that. Okay, so now I will start discussing the visual field defect. Okay, it's important, please. I need all of you to focus. Okay.
Are you okay with the previous part, doctor? I want to highlight that the diabetic eye is one of the most common eye cases that may appear in the exam. Okay. So simply you will go and you'll find one patient with blind vision in station 5 and history of diabetes, and that's it. And they are just examining two things. The first thing, your clinical skills to find the findings in the fundus. Okay, and they will give you the marks for the physical examination based on that, and that you know what to ask and what to examine in a diabetic patient. Okay, so if you just look to the eye and you will see what's there and you didn't check the other things, this will be a big problem. So remember the diabetic NPH, and remember that you need to look for the eye for the checking glucose checking scars. Okay, if the patient with this eye, and he told you that there is sudden loss of vision, for example, that extends for a while. So you need to mention the possibility of stroke or TIA. And if they want you to offer or to examine for carotid growth, they want you to examine for AF, for all the risk factors of blood clot, and ask about the risk factors other than diabetes as well for the blood clot. So please remember the diabetic issue. I want everyone to practice in his life 2 or 3 cases of diabetes. You remember when we practice the Charcot joint, and this is diabetic eye, whatever, peripheral neuropathy. So any form of a symptom that the patient of diabetes can appear with. Okay, you need to practice how to go through all the questions of diabetes. Give me the okay now in the chat box that you are okay with this part, because the coming part is very important. It needs more concentration because it is the visual field issue. Okay, and the visual field issue confusing for a lot, many of you. Okay, so I want to give it to you now. I know how tired you are, but these 2 parts are very important. So tell me, what do you feel? Did you learn something from this part? So Dr. Hadi said great. Dr. David said okay. What about the others? Do you feel that this is tough? Okay, Dr. Sharif, you're okay? Okay. Okay, good. So I want to get you while you're still awake. And this is why I'm selecting today, because I want you on this stage to still, it's still 1 p.m. or 2 p.m. there, so you are awake. So let's proceed with this part.
Give me a second, please. Let me tell you exactly what's going on. Okay, now. The second principle here will be all the component of the visual pathway. Okay, let me show you something here in this diagram. I will show you that this part of the eye. Okay, I will talk about the right sides of the eyes and the left sides of the eyes. So for now, forget about nasal and temporal. I will not talk about nasal and temporal because this is the confusion. Here I will talk about the right sides of the eyes and the left sides of the eyes. So let's imagine this part which is called, okay, the right side of the right eye. In my name now, I call it the right side of the right eye, the right side of the left eye, both together. Okay, we come together here and go down to make the right optic tract. Okay, so the right side here coming to form the optic tract, and I'll tell you why we divide it that way. So the brown color is for the right part of the right eye, the right part of the left eye. Okay, I'm not talking nasal, I'm not talking temporal. Okay, and the red part of the eye, okay, this red part is the left side of both eyes. Left side of both eyes. This is the first principle I want you to know today. I'll talk about the right side, which is go to the right. It's the right side going to the right lateral geniculate body, and the left side which union and go to the left lateral geniculate body. Okay, this is the first principle. The second principle here will be the right sides I'm talking about is responsible to deal with the light or the vision of the left side. So when the sun, this light source is on the left side, it's brown because it will be reflected, it will be seen by the brown part, by the right part. So the right part of my eyes, both eyes, responsible of the vision of the left side. So whenever I have a problem in the right side of the vision, the problem will be on the left side. Okay, when I have a problem in the left side of the vision, the problem will be in the right side. You got this point? This light coming here. Okay, this light, please look close your mics. I'll close now. Okay, so again, if this is clear, this is the right sides of both eyes. Forget about temporal and nasal. Left side of both eyes. The right sides are responsible for. Doctor, here I'm talking about the retina. Okay, so this is the right side of the retina, and this is the right side of the retina in both eyes. So when the light comes from here, it will fall. Forget about the eye itself. It's about the retina now. This will be received on the right part of the retina and this right part of the retina, which are both going together and union together in this optic tract. Okay, so if you look to this eye, okay, this is the temporal part of this eye. Let's consider this is the nose. Okay, so this is the temporal side of this eye, and this is the nasal side of this eye. So you see this light coming on the nasal side and on the right. This coming on the temporal side, but going to the right also. So forget about nasal and temporal, and remember that when we have a problem to look on the vision in the left, something moving in the left, the fingers moving in the left. Okay, this should be seen by the right part of the retina and the right part of the retina. Let's continue. Receiving the light of the left side. So whenever the patient have a problem in the vision of the left side, his problem will be on the right side of his eye. And the opposite, vice versa, will be that here. The patient have a problem in the vision coming from the right side. Okay, it will be the problem on the left side of both eyes. Do you agree with that? Okay. So the other part I want to discuss, the other principle here, and then I will go to the pathology. Okay. This part is called, when we talk about this part, we'll call it a temporal hemiretina. It's temporal hemiretina. And this part is called temporal hemiretina. I mean, it is not related to which light, which vision. I'm talking about the retina itself. For the retina, this part called temporal hemiretina. This part temporal hemiretina. And this part is called nasal hemiretina. And this part called nasal hemiretina. I don't want to confuse you, but you need to know these names because we will use while we're discussing. And again, being nasal hemiretina does not mean nasal vision. It is the opposite. The nasal hemiretina receiving the vision of the temporal part. Okay, so don't confuse yourself. The light coming from here, okay, going to this eye, the right eye, to the temporal, and here to the nasal. You see, the light coming from here going nasal, although it is reflected on the temporal hemiretina. Okay, but it's coming to the nasal vision. So this is the nasal vision of this eye and the temporal vision of this eye. Okay, this is the red part. So don't confuse yourself. Again, remember the two principles I told you. The first principle, I'm talking about the right side of the eyes, going to the same optic tract, going to the same geniculate body, responsible for the left vision. The left field vision, and the opposite going responsible for the right left vision. You agree with that? Okay. So I want you now to start answering with me. Okay, I don't want to have only one side lecture for this specifically because this will give me your understanding. Okay, so I open the chat for everyone in the chat box to write. Let's think here that we have this. We have the lesion here. Okay, this is the lesion. This is the lesion. Okay, what do you think? What do you think will be the problem when you have this vision? How will the eye be affected? Give me an answer in the chat box, doctor. Left eye blindness. Great. Everyone agree with that? Yeah, blindness in the left eye. Blindness in the left eye, Dr. Hina. Okay? Okay. Why? Because here we cut both the nasal hemiretina of the left eye and the temporal hemiretina of the left eye. So this patient can't receive any light from here, can't receive any light from here. So this left eye can't see whether the temporal or nasal. So this eye is totally blind or totally blurred because the lesion here compressing the optic nerve, the left optic nerve with its two nasal and temporal components. You agree with that? So whenever the lesion is in the optic nerve, when I found only one eye become blind and the other eye is okay, I'm talking about the lesion in the optic nerve. What could be the cause? It could be TIA, it could be multiple sclerosis, and this is not very common to have it acutely. Okay, it could be any cause of optic atrophy. Any cause of optic atrophy can cause the affection of the optic nerve. Okay, demyelination like multiple sclerosis, lippers. So you all know the ABC, the pale disc causes of the optic atrophy. So here all the causes of optic atrophy can cause this unilateral, okay, or monoocular loss of vision. Okay, the other eye will be normal. We agree with this? Okay. So now let's clear that and let's go to the next level. This is what's called the optic chiasm. Okay, the optic chiasm. And in the optic chiasm, there is a crossing of this part, one of the red part, and one of the brown part. But both of them are responsible of receiving, just a second, both of them are responsible for receiving the vision that's coming from the temporal. Look here, this part taking the temporal vision on the right side, right? And this part taking the temporal vision going to the left eye. So when I have this one and this one destroyed, when I have a problem here and I have a problem here, so this patient can see the temporal field here and the temporal field here, but they still can't see this light going here, so he still can see the nasal component of the left side, and he still can see the nasal component of the right side. You agree with me for that? Because the distraction will be here. These are, here I have a tumor, here I have a problem, and this problem compressing these components. This one related to this hemi section, this hemi retina, and this part is related to this hemi retina, and both of them are receiving the temporal vision. So here, the temporal vision affected, but the nasal vision still can come through here, and the nasal vision can come through here. So if I have a lesion that compressing the optic chiasma, this will cause what is called high temporal hemianopia. This patient will have an effect on seeing everything coming from this side and from this side, okay, because there is a problem here in these two components of the optic nerves. So I would expect this patient to have blindness here and blindness here, and the nasal component will be normal. So this patient, when I'm examining his visual field, I found that he can see nasally, but when I start to examine his visual field, as you will see, as we discussed in the clinical examination of the eye, you will find that he can't see your fingers. You see your fingers very early, but he can't see the periphery of the vision. You just see your fingers when it become in the front of his nasal field, okay? So this is why optic compression, optic chiasma compression by tumors, by pituitary, and this is the main, prolectinoma and acromegaly, with craniopharyngioma in the kids, which show calcifications of the X-ray, with suprasellar meningioma, with aneurysm, okay? All these can cause compression, but for sure, for our exam, the most common cause is the pituitary adenoma, because this is the place of the pituitary adenoma. Although there is rare cases like glioma, like granuloma, like metastasis, but here, whenever we talk about compression, this is the site of the pituitary, so should exclude the symptoms of prolectinoma and acromegaly, okay? So did you understand now what's the bitemporal hemianopia and how it's happening? Please confirm in the chat box that you understand the bitemporal hemianopia, how it happened pathologically. Confirm in the chat box, please. Okay, great. Dr. Shaima, you said I can see over the figure the nerves affected will be binasal ones. Okay, let me show you. Binasal, when we talk about, when we consider the patient have bitemporal hemianopia, that means that he can't see the things from the outer side of his eyes, right? Right, Dr. Shaima, open your mic, please. Let me open your mic. Then, okay, I open your mic, Dr. Shaima. When we say the patient has bitemporal hemianopia, forget about his eye now, forget about the inside the eye. When the patient has bitemporal hemianopia, this means, okay, he can see the things coming from outside, right? From the temporal sides, light. Let's say this is some things on the side, this is another thing on the side. So when the patient has bitemporal hemianopia, so he can see the things on both sides, outside, correct? Okay, that's why I start by telling you that temporal vision, the things on the temporal sides, can be seen by the nasal side of the retina. You see, to see this thing in the temporal side of the eye, it should be reflected here on the nasal side of the retina. Okay, so when the patient has a problem here in this part, he will not be able to see the things on the temporal side. This is the temporal vision. This is called the temporal vision. So the lesion, yes, it is in the nasal parts of the retina, but the nasal parts of the retina are responsible to see the temporal parts of life. That's why the patient will have bitemporal hemianopia, because he has a problem in his nasal side or nasal retina. Okay, so you see, when you compress here, the lesion will come here in these nasal parts, which is responsible for receiving the temporal vision. So this is called, we call it by the defect of the patient vision, not the defect in the patient eye. So the patient with bitemporal hemianopia, okay, he has a problem in seeing the temporal things, which is reflected on the nasal retina, which is already affected by the compression of the optic chiasma. Is it clear now?
Yes, I can understand you, but I just get confused between the visual field and the site of vision in the eye. That's why I was confused.
So is it clear now?
No, yes.
Okay, great.
Thank you.
Okay, welcome. Yes. Okay, doctor, thank you. That's enough. In the coming part, there will be one point confused. I will tell you about change here. I did something wrong in this row, but I will discuss it, okay? And then, that's great. So then we'll go now to the other part at which they asked it in the exam when we asked today the doctor, and we told him that where do you think the lesion? Okay, when the lesion, when there is a hemodynamic hemianopia, which means that the patient can only see. Before that, I want to show you something. What can we found if the opposite to compression here happened? Okay, I mean the compression was not here, the compression was there. You found that there is a compression here and compression here in this component. So here we lost this part and we lost this part. So here we lost the nasal vision, but the temporal vision is okay. So this is called binasal hemianopia, which is not common. Do you know why it is not common? Because here one lesion only can cause the bitemporal hemianopia. But here I should have two lesions. I should have two aneurysms or tumor compressing this component, okay, of the optic nerves, which is the temporal components, okay, that's going out because the binasal hemianopia, okay. Usually when there is an internal carotid artery aneurysm, bilateral internal carotid artery aneurysm, it will be compressing this side and this side, and when it's compressing both of them, okay, you will have a vision. Temporal vision is preserved and the nasal vision is affected, so it will be called binasal hemianopia, okay, which is not common. The common one, the very common one, is the hemodynamic hemianopia, okay, or hemodynamic hemianopsia, okay. It is any lesion, post-chiasmal lesion will cause it. Any lesion, post-chiasmal, I mean below the level of the optic chiasma can cause it. And it's very simple when you understand the principle. Let's say that the lesion is here. Okay, so now we cut this side, the brown side, and this side. So we cut the brown side that's responsible of receiving the light from the left side. As you said, we said the right sides of the eyes, the right side, the first thing I said in the lecture, the right sides of the eyes responsible for receiving the light from the left side. So when the patient coming to you and tell you that he can't see the left side, this means that he has the problem in the right side of his both eyes. So why the patient can have right side problem in right side of his both eyes? This is because there is a lesion at this level, lesion at this level, lesion at this level, lesion at this level. So at any level below the chiasma, we can find the hemodynamic hemianopsia. Okay. You understand the point? Now this patient can't see the light coming from here. This is the temporal vision of the left eye and the nasal vision of the right eyes, because all the right side is affected. So all the light that's coming from the left side can't be seen. So he lost the vision on the left side, on the whole left side, okay, because he has an effect on the right side of both eyes. So this is what's called hemianopia. If it is in the opposite direction, I mean, here is the problem, okay, he has that lesion here. When the lesion is here, you will have a problem here and here. So the patient can see the temporal vision from right side and the nasal vision from the left side. And this is the case here. Look, the patient have darkness on this side, the nasal on the right side, and the temporal, the nasal vision on the left side and the temporal vision on the right side. Okay, so when you have this problem, who can't see, okay, you have a right hemianopia, okay, his problem will be in the left optic radiation. Okay, if the problem is left optic radiation, you will have a problem. This patient will tell you that I can't see that anything on the right side, anything coming from the right side, I can't see it. So the problem will be in the left, okay, optic tract, in the left lateral geniculate body, and the left optic radiation, and even in the left cerebral cortex. Okay, and we will say some criteria. If you are asked in the exam, okay, if you are asked in the exam, and anybody told you, okay, where is the lesion? Will you just say it's post-chiasmal? Post-chiasmal. You know this hemianopia? Okay, it's called post-chiasmal. Any level of the post-chiasmal will cause hemianopia. Okay, so this patient here, he can't see the right side. Okay, he can't see the right side because he has the problem in his left, okay, his left optic tract, okay, or his left geniculate body, or his left optic radiation. You agree with that? Because we'll go to the next details. So there is. Doctor, confirm please that you understand this point now. When the patient can't see all, the first one I discussed was about the patient who can't see bitemporal, he can see both sides, both outer sides, or both inner sides. Okay, so this is binasal hemianopia, and this is bitemporal hemianopia. But when the patient coming and he can't see anything on the right side, he said, oh, the right side, I can't see it. When you look by your right side, now I need everyone while you are sitting, try to look to something on your right side. You will find that look to the light in your room, or look to the screen in your room, just on your right side. You will find that the light coming on your temporal side, okay, from the temporal vision of your right eye, okay, and the nasal side from your left eye. So if you have a problem in both these items, okay, both these parts of the retina, the right side of your world will be blind. So you will have you will have full right hemianopia. So it will be dark, anything in the right, you can't see it. And this is because you have post-chiasmal problem on the left side. So if I have a problem here, okay, I can't see any light on the right. Okay, so whenever the patient coming with, you check his visual field, and in fact he can see your right side, but he can see your hand when you are doing the left side. So he have the hemianopia, okay, which is related to post-chiasmal, whether it is the optic tract or geniculate body, the opposite geniculate body, or the opposite to the side, to the lost side. Patient can see the right, so the problem in the left. Patient can see the left, so the problem in the right. Okay, is it clear now? Simply as I told you, patient came with hemianopia, can see the right side. Just tell him post-chiasmal left side. Okay, and mention the post-chiasmal could be optic tract, could be geniculate body, could be optic radiation. Give me yes. I want everyone to confirm that you understand. I will not proceed before you confirm. Forget about this one, because this one I draw. This is not right. This is left. I wrote it right, but the blind part I put in the left. So this should be the right should be dark. Okay. Anyway, it's the opposite. Just this picture should be the dark part should be here on the right, but the right hemianopia will be for the left affection. And if it is left hemianopia, so it will be right optic tract or lateral geniculate body or left. Okay. Thank you, Dr. Rashid. Thank you, Dr. Mir. Thank you, Dr. Abdulaziz. Okay, good. I hope you will not forget it in your life. Question: your description on the slide is right, isn't that supposed to left? Which one? Oh, you mean this one? Yeah. This slide is wrong. The right should be here. This is the right. This is the right. The photo just need to be turned. Okay. Yeah. So forget about this. This is the opposite. This is right. So the blind spot should be right, and the affected is the left. Or you can make it easy by changing it to left hemianopia and right tracts. Okay. But this came in the exam. I didn't add this to our lecture. I added 1 year ago because it came in the exam. There's two cases came with the hemianopia. So many candidates asked me at that time how we approach that, and we can't understand that. So I prepared this lecture because of that. Okay. So it's not just trying to show something which is not important. It is important, and localizing the lesion is important. Okay. Did you understand the principle? Forget about this one. Okay. I'm talking about patient can see the right side. He has the light coming from the right side. Okay, so there is right hemianopia. Okay, why? Because the light coming from the right, which is presented on the left side of both eyes. So I would expect to have a problem on the left optic tract, on the left lateral geniculate body, and the left radial radiation of the corpus. You agree? Do you understand the principle of that? So whenever I'm asking, and this is for the faces, they will just ask this in the faces. When it could be the lesion, I would say post-chiasmal. Okay, it could be optic tract, it could be lateral geniculate, it could be optic radiation, it could be the visual cortex. But remember, when it is in the visual cortex, there should be something a little bit different, which is called the macular sparing. What's meant by macular sparing? With macular sparing, the macula is spared. So the patient have a visual field defect on the right side, but he still have the central vision to 30 degrees from the middle of his eyes, and this is very difficult. This will be this is very difficult to detect during examination, but you can see it in the visual field examination. You'll find in the Zoom when you see any report for visual field, there is a macular sparing. Okay, to your knowledge, macular sparing, I can say that for the examiner. I would expect the presence of macular sparing if it's an occipital stroke, for example. Okay, because the macula, there is two principles for that. They found two explanations for that. Because the macula taking two blood supply from the posterior cerebral artery and from the middle cerebral artery. So when there is a posterior stroke, okay, posterior cerebral artery thrombosis, there is still the macula still taking blood supply from the middle cerebral artery. So the macula still spared from the loss of vision. Let me clarify this point, doctor. This optic radiation is already in the cortex. So here there is a cortex. Okay. When there is affection of this, as I discussed now, it will cause the same. It will cause hemianopia, right? It will cause the hemianopia, correct? Okay. But when it is in the cortex, the patient will not have a total blind sight, not total blind left vision or total blind right vision. There will be what's called macular sparing. So the central vision will be preserved. So if you see how it looks like, there will be a circle here, there will be a circle here, because the macula is still clear. Why? Because in the cortex, the macula itself, the macula of the retina, this part, will be taking a double blood supply. So even if there is a stroke affecting the cortex here, okay, the macula still have receiving blood supply. So this explains what's meant by there is sparing of the macula. So the patient will have the hemanopsia, will have the bitemporal, depending on whatever. Okay, but I mean, if it is in the cortex, okay, and hemanitis hemanopia will be there with sparing of the macula, this will be because the macula receives double blood supply. Okay, and some theories saying that the macula is presented on the cortex in two spots. So even if one spot is affected, the other spot is spared unless it is diffuse affection of the occipital cortex. You got the point? Okay. The only remaining thing, again, I don't find it is really important in the bases at all. It's not important in the bases. What if this part is affected? What if this part is the affected part? I mean, this is the optic radiation, and this optic radiation, this part of the optic radiation is presented on the temporal lobe. Okay, and this part is presented in parietal lobe. If you see, there is a faint, I don't know if it's clear for you or not. This is the cerebral cortex. Okay, so this part is in parietal lobe, this part in parietal lobe, and this part in the temporal lobe. Okay, the part of the optic radiation in the parietal lobe, which is called Meyer's lobe. Okay, this part is presented in the lowermost part of the retina. Okay, which is receiving the vision of the superior vision of the eye. So let me show you this picture, and you understand. Although this is very unapplicable in the exam, then we'll go back to this slide. Okay. This slide will make clear for you, just to your knowledge. Okay, this is the upper visual field. Okay, going here and then go to the lower part, which is the Meyer's lobe. The Meyer's lobe is in the temporal. Okay, this part is in the temporal. Sorry. This part is in the temporal lobe. So whenever I have a temporal stroke or temporal lesion, I will expect to find a superior visual field defect. Okay, and because this is only part of the optic radiation, it will not be complete. It could be quadruple. It could be what is called quadrantinopia. It could be quadrantinopia. This patient exactly will describe his vision problem like a pie in the sky. Because there is a blind area in the top of his vision, he will see like some pie floating there and flying on the sky. So it's called pie in the sky. Okay, this is a temporal lesion. Temporal lesion. This part of Meyer's lobe of the optic radiation present in the temporal lobe. Okay, and because this part is representing the superior visual field, you see superior visual field here going here down the temporal lobe. So you will find what is called quadrantinopia. Okay, so remember the word of step. Okay, step mean superior for temporal, inferior for parietal. Okay, so superior visual field will be the temporal affection, and inferior temporal field will be for the parietal. And I think you remember that from the part 1 and part 2 MRCP. Okay, again, if you're asking me how this will be applicable in the exam, nothing. In the basic exam, you need to know when it is homonymous hemianopsia to say that it is post-chiasmal lesion. It could be an optic tract, it could be in the lateral nuclear body, it could be in the optic radiation, it could be occipital stroke. And I would like to check all the reasons for that, all the causes that can cause this. Okay, so let me go back now and show you here. The most important, the patient with homonymous hemianopsia will say, I can't see a side. So the case will be in the faces saying, blind vision, when you ask about the details, he will say, I can't see a side. I can't see the right side, I can't see the left side. Okay, so he'll describe a side, not the sides. If he said, I can't see the sides of the vision, this is bitemporal. He can see left side only, he can see right side only, will mean that he is talking about homonymous hemianopsia. Okay, he will not say, I can see in one eye. Okay. Okay, so Dr. Asman said there was a case in patients recently with superior quadrantinal. Great. So now you understand the principle. The lesion is in the temporal, and the patient will describe a pie in the sky. If they have a case with superior quadrantinal, this is great. Okay, so now you understand the principle for that. Again, what would be the causes for that? I can see a side for the homonymous hemianopsia. Okay, there could be the cause of, remember the word of vitamin, which is the vite. The V for vascular, TIA and stroke and hemorrhage. The I for interventions like surgical interventions. Patient have a surgery and they make an injury to the optic tract. Tumors and trauma. Uncommon causes for that will be multiple sclerosis, infections, and seizures. Okay, so if you are asking what could be the cause of this, I would say stroke. The first thing, if it is temporary, TIA, if it is persistent, I would say stroke. Occipital stroke, any stroke can affect any part of the post-chiasm. Okay, then surgical intervention, then tumor and trauma. Okay, for the bitemporal hemianopsia, it will be I can't see outer side of my eye. I'm pumping objects. I keep breaking my car mirror. Okay, so the causes could be pituitary adenoma, craniopharyngioma, and could be aneurysm. Okay. So this page I want you to print. It's very important because this from UpToDate. It's describing every lesion and how it's affecting. I will not go through all the details, but it's like when it is a giant cell arteritis, the configuration is variable depending on the treatment. Usually it's monocular. Symptoms are headache, neck pain, joint medication. The mechanism ischemia having to the optic nerve. So this describes every lesion, how it will be presented, for how long, and what's the mechanism of the pathology. Okay. So if it's migraine, it takes 10 to 30 minutes loss of vision, transit loss of vision. Usually binocular positive symptoms will spread. Usually following migraine, headache, spreading cortical depression. This is the mechanism. Okay. So when you read this, you'll understand when they bring an acute temporary case of loss of vision, you'll understand by the criteria they give it to you what they are hiding and the scenario. Okay. So this was what we discussed here: the optic radiation and the reticular body and the optic tract and the optic nerves and the visual field. Okay. And this is the cases that can come in the exam for the visual field. The first one, as we said, the homonymous hemianopsia. Okay, and we said that the likely cause could be cerebrovascular, as we said, the VIT. We'll not go through again. Then bitemporal visual field, as we said, pituitary tumor, craniopharyngioma. Then the tunnel vision. The tunnel vision can come again, which is bitemporal again. The patient can see only in the middle, but totally tunnel vision, as retinitis pigmentosa and glaucoma. And the third cause, I need you to know the excessive laser coagulation for the eye. The photocoagulation of the eye, when it is excessive to the periphery for the proliferative retinopathy, it causes tunnel vision. Then the central scotoma, when there is an affection of a certain part, which is called the pool of the occipital cord, it can cause central scotoma, and the optic atrophy. Any cause of optic atrophy will cause central vision problem. Okay, so all the causes of optic atrophy can cause central vision problem. Then the homonymous upper quadrant, which is the temporal lobe affection, and this is the case that the doctor is telling me now just came in the exam. Okay, so now you understand why it is up, why it is temporal. Okay, why it is affecting the temporal part of the eye. And as I told you, this is the upper and lower visual field. Okay, questions, doctor, about that?
Doctor, now tell me about your understanding of the part we finished. Dr. Nouman, Dr. Sharif, Dr. Al-Hadi, Dr. Mina. I know this may be too much, but you should understand that in some stage. I'm not expecting you to get it all at the same time, but when you review that, when you watch the record again, you will, maybe if you missed something, you'll understand it. So, Dr. Nouman, want to ask something? Yes,
Yes, sir. Yes, sir. Assalamu alaikum, sir. I want to ask this superior quadrantenopia or inferior quadrantenopia can be part of bitemporal hemianopia?
It will not be in bitemporal hemianopia. It can be full and it can be partial. Actually, in the exam, they're not expecting you to catch it, exactly. You know what I mean? Because usually this need what's called perimetry.
Yes.
The perimetry will show exactly which part of the vision is missed. While you're examining the visual field, it will not give you this accurate exactly what's going on. Unless the patient told you that I see a firefly in the sky or something, he will be giving you the answer. But otherwise, they're not expecting you to be ophthalmologist,
Oh, yes. He is saying that it was superior quadrantenopia, and he was given the differentials of bitemporal hemianopia, like pituitary adenoma and craniopharyngioma. And then the examiner was also satisfied. So I confused that time it can.
That's what I'm telling you. He was satisfied, right?
Yeah.
Yeah, this is what I'm telling you. They're not expecting you to do that. They want you to catch that there is a field defect and it is bitemporal and you have the differential for that. I mean, he will guess your understanding when you just study this part. I don't want you to dig deeper in things that they are not going deep in that. The slides you receive, just study the slides I'm going to send to you, and this will be more than enough regarding this part. Okay.
Okay. Okay. Thank you. Thank you.
So, did you understand it? You like the way we discussed that?
Yes, sir. Very nice. Good guideline. Good slides.
Great. Thank you. Yes, Dr. Mina, the last part needs to study, yes. So now there is a part remaining, but we are finished 6 hours now, so I don't know how much you can tolerate. If you can tolerate more, or this is enough. With the remaining thing is a case for ptosis. So if you want me to send you a record for the ptosis, it's okay. If you want to proceed, it's okay as well. I think after 6 hours, I want to give you some chance to digest what we said. Otherwise, I will be like filling more than I should do. So what about the ptosis? Are you okay? We can. I think I can. Whether we can start the next on Saturday, tomorrow night with, or maybe I will let Dr. Ahmed send you a record for the part of the ptosis, so you'll get an idea about the ptosis and the differential diagnosis for the ptosis. What do you think? What's your opinion? Tell me in the chat box. Hello. I think it will be a good idea to send Dr. Record after Sunday. Okay, some of you give Dr. Mina saying record after Sunday for the ptosis. Dr. Adams, you can start with the issue. The day of Saturday, there is a lot of things we are going to discuss as well. So starting with 1 hour of ptosis will be a little bit confusing, and we'll keep missing one part in the end of the lecture. So okay, it's a good idea. We will proceed as we are doing, and then I will send you the record to watch after Sunday. It's a good idea because you have Monday and Tuesday, so you can watch a record for the ptosis. It will not be the ptosis only. I will send you also some of the lectures I want you to watch of the 3 lectures again. Okay. So tell me, what do you think about today? Heavy day? Is it heavy one? The blurring of vision, the syncope, all this stuff a little bit heavy, right? I know. Usually this is the heaviest day in the course because the 2 topics are heavy as well, but they're important, and this is the way to do it. They are important. Dr. Afra said yes, but very informative. But Dr. Sahar said heavy, but learns a lot. I'm sleeping after on call. Good, interesting, really great. Thank you very much. Thank you, Dr. Hadi. Thank you, Dr. Mina. Thank you, Dr. Fauzi. The idea usually I'm saying after preparing for PACES, you'll learn a lot of things, not from my course only, from your clinical course as well. I mean, if you are a different doctor, not after passing the PACES, it's after preparing for PACES. Believe me, you will have a different idea. Your understanding for the things will go more deep. You will know things that others know nothing about. That I mean, you will not meet a lot of doctor who knows how to examine a patient with tuberous sclerosis, for example, who knows anything about hemorrhagic. They just know these things by name. At the time, you know how to ask them how to examine. Your approach for your patients in your clinic will be different. When you take your clinical course, you'll find that hey, eventually I can recognize any murmur. I can put my stethoscope and say this is lung fibrosis. I can check if the trachea is shifted or not. Really, not as in the medical school. You will examine the patient neurologically, so everyone will watch you doing that will be impressed. So believe me, doctor, everything you will learn during preparing for PACES, you are building your skills in the medicine. That's why I told you in the beginning of the course. Remember, you are learning. Make your objective is to learn a lot of things. Then eventually the exam will be a simple thing. So if you see that now we are the approaches before today, for example, you don't know if one patient came to you blind of vision, you don't know how to start, what to ask, when to put the headache, when it is about syncope, you know all the knowledge, but you never organize that. Okay, in every algorithm we discussed. So I mean, eventually I want your brain. I trust your knowledge. You all have great knowledge, but my objective is to put it in the correct order and make it accessible for you to use it. I mean, you can't just search in certain place in your brain to ask the question. So blind of vision is a nightmare, but if you have blind of vision with the algorithm and what we discussed in the fundus today, so at least 60% of your fear improve. Then once you practice some ophthalmoscopy and this stuff, fundoscopy, you will feel super confident. You agree with me? Okay, so thank you, doctors. Thank you for your nice words, and I hope you learned something. It's 3:30 on my time now, 3:30 a.m. So I should go to sleep, and because I have work after 3 hours as well, 3.5 hours. So I hope you enjoyed today. You learned some stuff. If you have any questions, send to me in private message on the WhatsApp. Okay. Don't forget to check these 2 cases. Another case I want you to let me tell you about it. No, we will practice this case. We will practice it when I have time. So I will not tell you where to read it. Okay. So today was a heavy day, not more practicing, but more topics to learn. Okay. Any question before I leave? Any questions, doctor? Thank you, Dr. David, as well. Thank you, Dr. El Hadi. Thank you all, guys. See you tomorrow, inshallah. Thank you, Dr. Afra. Thank you. Thank you, Dr. Sam. Thanks, Dr. Fauzi. Thank you very much. Thank you. So, okay, so let's go to the first case. Ready?
Okay.
Okay.